So thank you very much, everybody, for coming for uh, Lung Cancer Chakravyuh Season 2. And our first batsman is Dr. Nikhil Gadial Patil and Dr. Manish Jain. So over to you, Nikhil and Manish.
Thank you, sir.
Uh, Thank you, Dr. Parikh, for this opportunity and for this wonderful platform of Chakravyuh of on lung cancer. We don't have much time, so let us start directly to the point in discussion, and that is mediclaim tip and how to get insurance companies pay for the oral chemotherapies, especially the TKIs what we use in the lung cancer. So the plan would be probably I will be asking Dr. Manish Jain certain questions and his experience about insurance, especially in the field of TKIs in lung cancer, and we will have some practical tips and take-home messages in this process. So this was one of the important papers again through Medicalogic initiative, and this was about the insurance challenges and solutions. Of course, I'll go through it as in the last couple of minutes. So, Dr. Minish, so you work in a giant corporate hospital in Pune. So, what are your prominent challenges, especially when you really have patients like this who actually are right candidates for TKI therapy in lung cancer, and what are the challenges you have faced in such scenario?
See, generally the first admission is a very easy admission because by that time you're biopsying them and diagnosing them. And when you write the investigations, medicines, everything is being covered in that first 3 months. The challenges come up when actually you're going to treat them further. If somebody goes on crizotinib or ceritinib or alectinib, then the cost is so high that the insurance companies don't want to cover. And they say that these are not chemotherapy, so they don't want to cover anything which is not chemotherapy. So anything which is like whether you're giving denosuzumab or zoledronic, that is also being not covered. Lost a lot of time, they reject even the police plans and all. They cancel this, they make it as an adjunct treatment, so no adjunct is being covered. So it becomes a real difficult thing. Patients, like one of our patient who was the Bajaj insurance person, he could claim his alectinib very easily. But if you look at other patients, they may not even get crizotinib. So that is how things are. And sometimes you have to go for the alternative generic drugs and go for it. That's the only thing. Patients don't get their money then.
So,
Then
do you recommend the patients to buy the medications and subsequently submit the bills to the insurance department? Have
see,
you done it?
what is happening is we are not reading the lines. If somebody wants to really cover up for cancer treatments, they should go for cancer comprehensive policies. There are ICICI, HDFC and Regon. They have their comprehensive cancer policies, which is exclusively, they have either two ways. Once you get the cancer diagnosed, you get the lump sum and they don't look at it. And the others are, they cover everything including your transport. So if somebody wants really, they should not go only for a general mediclaim. It should be a very specific cancer policy, especially for patients who have family histories, who have otherwise high risk things, like if they are smokers, they're working in a place where cancer is high, then those kind of people should go for. And now there are certain recommendations being done by the companies, or including the insurance companies are being now forced to pay for this. So I don't know whether these policies will come in practice or not, but right now it's not easy for everybody. We are trying to figure it out, like we have trials, so we are putting the patients on trials even if they are affording. Then we have alternative ways, like whenever every 3 4 months we admit them for something, then they get a claim. So that is another way of doing it. And then we find the cheaper options, like Pablocyclib has 10 months and free, or Ribocyclib
Okay,
has 10 months and free.
we will discuss on that. But how frequently you have actually approached insurance company? I mean, through your letters, so that the insurance claim eventually gets covered. Have you done it in your practice?
We have given them guidelines every time, and we have asked them to take a second opinion from Tata and then submit that Tata and the guidelines things to the companies through their lawyers. And this is how they have to negotiate and get it done. So we directly do not get involved into it, but what we do is we give them a guideline that this is your treatment. We get a second opinion from Navya or Tata. We ask them to submit that paper along with our paper, and then put a legal notice to the insurance company.
Okay. So one more problem what I often have seen is this smoking issues with the patient. Sometimes somewhere it is written that the patient is smoker and the claim gets rejected. So has it happened in your practice also?
We are very careful in writing up the insurance things. Whenever we do that, we tell the patients don't give wrong histories. So if you
Okay.
give histories, we are not responsible, because I have seen companies, people, if the claims are big, then they have their own doctors who come and check the papers, and they evaluate and they reject even at a later date. So make
Okay.
sure that the histories are not being written down.
Manipulated.
No, you don't write it. You
Okay.
can see omission is better than commission. So commit it. Just omit it. Don't write
Okay.
it. Or tell them, don't tell the junior doctor. The problem is not with us. The problem is with junior doctors. When they get admitted, somebody is writing the history. The first history, they might have mentioned smoking. So if they can avoid it, if you can tell your patients right up front. We all
For
know that smoking may not be the only reason. It's a very small reason for lung cancer.
Nikhil, you have
No.
4 minutes left.
Yes, yes. So let us quickly go through this particular study what has been presented, and it's quite an interesting study. So this was more about the experience by the oncologist in terms of companies, and there it was basically a questionnaire. And here, in this particular question, when the respondents were asked about the refusal of cashless approval, you can see that almost 55 plus 40 means 95% of patient had some kind of cashless approval in terms of refusal in terms of cashless approval over here. And you also, when you look at rejection also, again majority of the doctors have faced rejection. Only very handful of doctors who actually had not seen any rejections in terms of when you talk about the insurance claims over here. Similar has been the situation for the claim amounts. Again, majority of the doctors have experienced that the insurance companies have reduced the claim amounts over here. And again, clarification and explanation. I think all the I believe the entire audience probably must have come across some certain situations where you are kind of compelled to write another explanation, a couple of clarification, and despite that, the eventually the claim does get rejected. That is very common situation, I would say. So there are definitely problems. There are treatments. There are certain treatments like for that, for the matter of TKIs, that there are treatments without admissions, and these are really, I would say, quite a practical issues what we are actually coming across. And Dr. Minish had given quite important insights on what are the things probably one can do at their own level, like getting a second opinion, and for that matter also attaching the guidelines. And that way probably one can also have a, in a more appropriate way, one can try and I would say follow the insurance pathway for the patients. So again, this particular question I also asked, did your letter to insurance company result in benefit to your patients? So again, 50% of respondents said yes. So that is very important. Let me just quickly skip this slide. And this was one fact case which had which is a real life case where a stage 3 lung cancer was advised crizotinib as oral OPD TKI therapy, element being a life threatening and continuous expensive therapy and does not require hospitalization. And insurance company's argument for rejection was that 4.18 clause excludes OPD treatment, and patients were only allowed oral therapy in on OPD basis. Hence, the claim was rejected. So they have received similar complaints, denial of claims for oral chemotherapy, modern chemotherapy, as well as liposomal drugs. And IRDA has brought out circular that modern therapy drugs cannot be denied. So eventually, the New India Assurance Co is ordered to eventually settle some XYZ amount, and eventually was advised to pay the amount in the stipulated time. So we don't have much time. Dr. Minish, do you have any one quick practical tip for our audience in this particular insurance related challenges, especially in the lung cancer oral therapies? IV may not be the challenge to that extent.
No, as I said that, first is try to get all these insurance guidelines do mention that they do not cover ask them to do a better insurance. That's the first thing I would suggest. Make them to go for a cancer policies which cover everything. Don't go for only Mediclaim, which is a very general policy. Third, try and see which one is the best option for them, what can be afforded for a longer period. See, somebody affords alectinib for 1 month is not better than crizotinib, which can be afforded for 10 months. So go for things which are for longer terms, and see companies who can give free after a particular amount. Like most of the companies are giving free after a 10 months crizotinib, you get it lifetime free. So what we do is, like supposing somebody gets onto crizotinib and fails in the brain alone, then I do not stop crizotinib. I put them on radiation to brain and continue crizotinib, which is also a guideline. So you don't have to change to serotinib because now the patient is getting free. So I try and do things which can fit in for that patient for a longer period. Until that time, probably the next drug comes cheaper, then you go for the next drug. So this is how we manage or manipulate.
So great. I think our time is up, right, Dr. Parikh?
Yes, sir. The
As,
time is up, sir.
yes. So thank you, Dr. Minish, and thank you, Dr. Parikh,
Thanks,
for this
thank you.
opportunity.
Thank you so much, Nikhil sir and Minish sir, for the wonderful session. We'll move on to our next part of the program. Our moderator is Dr. Amish Vora, medical oncologist from New Delhi. His panelists are Dr. Bhavesh Parikh, senior medical oncologist from Ahmedabad, Dr. Ghanshyam Biswas, senior medical oncologist from Bhubaneswar, and Dr. Purvish Parikh, senior medical oncologist from Mumbai. Over to you, Amish sir.
Thank you. Can I have the next slide, please? So topic is slightly unusual today, but I assume it is quite relevant in our day-to-day practice. And, Ghanshyam also must be facing this issue on a daily basis. I have put here two cases, both for my own. One young boy, DLBCL, planned for R-CHOP. Patient could not afford rituximab. There was no insurance. They could afford CHOP, but we all know that our CHOP is essential. So how do we manage rituximab? That was one. Second patient was a widowed mother from Jammu. Son just got selected in army. Patient has relapsed ovarian cancer. Bevacizumab requires to be part of treatment. Salary is not enough for bevacizumab every 15 or 21 days, especially in ovary where 15 mg per kg per dose is required. Can I have next slide, please? We all know that 1 in 4 cancer patients, in fact, this is a Western data, in my day-to-day practice, it is 2 in 5 patients, they actually go bankrupt. They don't have money to run family when the cancer treatment for ovary, breast goes on for many years. Next slide, please. So my first question, Bhavesh Bhai and Dr. Ghanshyam, in your practice when such patients come, these two patients, one is curative, one is palliative, do you help them, or if yes, how do you help them? Bhavesh Bhai first.
Thank you, Amish. The first answer, generally for rituximab, there are some companies, pharma companies supporting like every 2, 1 molecule is free. For another 2, also the expense or the cost is the real issue. So for that, most of the times we are explaining or arguing that you can at least spare only for 1, and then remaining we can do for support from the pharma company or support from some trust or some donation also coming from some organization. For palliative treatment, again, is very difficult, but for army, we had an ex-serviceman, but as you rightly told, it is just an initial service to the army. So for palliative treatment, I had a very limited resource to support bevacizumab in recurrent ovarian.
Does your hospital where you work, do they support these patients in any form, especially in curative form? Quick answer, Bhavesh Bhai.
Yes, my hospital is supporting for the curative intent.
Okay, and how do they support?
They are claiming from the pharma company, they will support the injection. They are not costing that injection directly to the patient, and they support through the pharma company.
Great. Ghanshyam Bhai.
Yeah, good evening. So before I directly answer the question, so what I have done in last 15 years, so any patient with a curative intent who is motivated for treatment, the cost should not be a barrier. So I came back in 2005. So 2010, I started a United for a Cancer, where I started that fixed amount of my salary will go into that. And over the years, now 10 years, 2013, so I am active into clinical trials. At this moment, even in COVID times, I have 18 trials ongoing. So if I talk about rituximab, since the biosimilar is available, every year we have at least 2 clinical trial ongoing. So this is a phase 4 we can say. Coming to bevacizumab, last year in a clinical trial, phase 4, I have enrolled 76 patients. That was a INTAS, and now we are running a bevacizumab of a phase 4 of Dr. Reddy's. So we started 2 months back, already 9 patients. Third, 2018, I started a BS solutions because there are many patients who cannot afford. There are many patients who cannot be enrolled into a clinical trial for some inclusion and exclusion criteria. So these patients definitely, we take companies benefit and the help. And you know that if you are writing X amount for a particular company, so at times, even 4 cycles, 5 cycles can be given free.
Right. So Ghanshyam and Bhavesh Bhai, if I see pharmaceutical company, patient assisted program and enrolling in clinical trial and at the personal basis where donate some amount of money. Next slide, please. I did almost the same because I run my own organization. I wrote in plain paper, I got a writing from patients. I will return money in X amounts of time. There was no legal documentation. NHL patient got cured. CO ovary patient passed away after 1 year. It is 2 years since the loan and I still have not got any money back. Next slide, please. So similarly, I worked as a medical director in a US-based pharma company where they were neurology-based and drugs for multiple sclerosis, interferon alpha, to be taken for 2 years, 3 times a week. 1.8 lakh rupees per month was the cost multiplied by 24 months. So we came out with India-specific EMI scheme from the company itself. Again, this also failed miserably and we could not recover money in majority of the patient, and the global team, they said, Amish, shut down this. Next slide, please. So with this background, there are a lot of non-banking finance companies. And in fact, while we talk, I am also under negotiation with one such non-banking finance company for my own organization. They either directly give loan to patient or hospitals or through pharma companies. Next slide, please. So how do they work? They give a personal loan to individuals depending on the patient's or the family's capacity to pay back. The turnaround time is 3 days in approving loan. Loan period is up to 3 years, not more than that. This loan amount goes directly to hospital. This is something which is good because the patient, once it gets committed to the hospital, doctors also can then treat them better. Now, who ensures timely payment of EMI? Like I lost out on patients' money. It is finance company. It has got nothing to do, no liability on doctor or hospital. Next slide, please. I believe there is nothing like zero interest EMI. There's always something. So how do these finance companies make profit? But if you take Dr. Somsekhar's experience, Manipal Hospital, Bengaluru has used this scheme in more than 4,000 patients. In a similar webinar discussion, Dr. Somsekhar was there as a panelist, and he said within 6 to 8 hours, this non-banking finance company approves the loan and loan gets deposited in patient's name in the hospital, and then everything else is looked after by this non-banking finance company. And that is how the fees normally are picked up by the concerned hospital or pharma companies. So this is how they are working. Next slide, please. With this, we come to an important aspect of crowdfunding, and I would request Dr. Purvish Parikh sir to take over from here.
Right. So I'm sure everybody is aware of something called crowdfunding. And in crowdfunding using the internet, common people are requested to support either as a loan or a donation. A loan is commonly used by startup companies who will repay the crowdfunders back. And donations are usually used for medical purposes. So if you Google keto.org, you will see so many beautiful photographs. And these are really emotionally tugging to the heart, and people tend to donate. So this is how crowdfunding, which is a form of donation, which the patient does not have to give back, is possible today. Next slide, please. So if you go to the Keto website, they will say that they have already raised over the last so many years 1,100 crore rupees. I think that is very impressive. And more than 55 lakh donors have been there. And on an average, there are more than 2 lakh subscribers. And they have a 70% success rate. So this is not meant to cover the entire treatment of the patient. Maybe it covers 1 lakh, 2 lakhs amount, but it really helps the middle class who otherwise do not have a way of getting money. And this keto has been so successful that it is now featured in BBC as well as DNA India. Next slide. You will be glad to know that these are the three founders of keto.org. I have no disclaimer. I am not associated with that. I don't know keto. I don't know any of them. But I feel that this is really helpful to patients because if you have a potentially curative patient and you want to give rituximab, if you get a donation of 1 to 2 lakhs, I think it makes a big difference in water. And when Kunal Kapoor, very prominent personalities associated with it, we also feel confident in the reputation that they have gained. They have next slide. They already have an association with 180 hospitals and panels. They have been working since 8 years. And as far as cancer is concerned, they have helped about 5,000 patients every month. Sorry, not cancer, all healthcare related. They help 5,000 patients every month. Usual target is 1 lakh rupees, and this is raised in 4 to 5 days. Now, this is absolutely amazing in 4 to 5 days. And people have donated anywhere from 1 rupee to 5,000 normally, and a few people have donated 10,000 rupees also. Depends on how emotionally they connect. This is information provided by Keto to me in personal communication. I have not verified that myself. Next slide. So I'll now ask Bhavesh, Gancham, and Amish in that order. Would this help in your patients, and would you like to try crowdfunding? So let's start with Bhavesh.
Absolutely, sir. This is a wonderful news and very much informative. And I am definitely required some type of support. And I will be in future also, whenever any curative patients I need, I will definitely thought for crowdfunding.
So Bhavesh, they actually approached Shalby Hospital in Ahmedabad.
Okay.
And they were not able to connect to the right person.
Okay.
So can I ask the person to contact you, and
Yes.
then you make sure that they enter the hospital to the right person?
Perfect, sir.
Yeah, excellent. Gancham, I will ask you now for your comment.
So if I come to a crowdfunding, so as a donor, so maybe in last few years, so I have donated X amount of money. But what happens? So every now and then, so once they get your mail, so once you have donated, so they expect that you donate for every patient. So once you donated for an old age home, then they will come for the women's, then they will come for leukemias, their lymphomas. So that goes on. So unless and until, so many times they are forced. Second, so we have done a crowdfunding through local medias. So that at times helps. They come and verify. And even in this COVID time also, because of the lots of expenses, we got crowdfunding from the local. So 2 patients were helped, but they were in the palliative. So we lost both the patients.
Right. Amish, what about your?
Sir, I have raised crowdfunding for 2 of my patients by running
Awesome.
marathon.
Oh, wow.
Both were curative, one NHL, one leukemia. And I told people to donate anywhere from, so 1,000 rupee per every kilometer I run. So 21 kilometers, 21,000 rupees. In 6 days flat, both the times I could raise 6 lakh rupees. Both the patients are treated, cured. And after that, what I think is, if you have the right means and resource, the crowdfunding extremely, people are ready to help. They want to help to a particular patient.
Right.
So also Ghanshyam's point, people haunt me also all the time. I have created my own criterias where I will give crowdfunding. I stick to those criterias and politely say no to others. This is how we look at, but this is an amazing, amazing thing, sir.
Right. One participant, Sanket Shah, said that he has experience of crowdfunding. Sanket, can you share your experience, please?
So basically, I got this crowd sharing idea from one of my patient who is young patient and got some funding from multiple sites from Milap and Keto and 2-3 other sites, and he actually get the money for his bone marrow transplant also. So after that, I had also tried for another 2 or 3 patients. So I'm looking forward for that.
Fantastic. That is great news. So everybody who is listening, please understand that there are several platforms for crowdfunding. Crowdfunding actually works. Keto seems to be a very reliable platform of 8 years with such a large experience. And if we can generate funds of between 1 and 2 lakhs for our patients, particularly middle class patients, that goes a big way in ensuring that they can complete the internet treatment, and they will be extremely grateful. So please, anybody who's interested in connecting with Keto, please let me know by email or by WhatsApp, and I will try and put you directly in touch with these people.
Purvish sir, I just wanted to share one of my experience. Mangesh here.
Yeah, Mangesh, please go ahead.
Sir, recently we did 3 autologous bone marrow transplants for patients with myeloma and lymphoma respectively, with funds which we got from the CMPM fund. We got 5 lakhs per patient. So it is actually a very viable method. I used to actually not be very optimistic about it, and we get it. And now through Keto, we have raised 12 lakhs for a 8-year-old girl with thalassemia, whom we are going to transplant shortly with the MSD match. So it is possible if we put efforts, and we should do it early on rather than waiting for the 11th hour to get the funds.
Mangesh, that is great news, because that actually tells us that it's not 1-2 lakhs, you can get up to 10-12 lakhs as well. Thank you very much, everybody. Thank you, Amish, also. Since we have only 15 seconds left, I will hand over back to the organizers to go to the next session.
Thank you so much, sir. We'll move on to the next session. Our expert faculty for the next session are Dr. Raju Titus Chako and Dr. Ashish Singh, both medical oncologists from Velur.
Very good evening, friends and colleagues who have joined us for this Lung Cancer Chakravyuh Season 2. And it is my pleasure and privilege to actually welcome Dr. Raju Chako, who has been my mentor, I learned most of my oncology through him, right from the time I trained under him. And today we are thankful to the organizers for this platform, where I thought I can bring his vast experience and his wisdom to you all regarding the topic given to us is treatment of lung cancer. So welcome, sir. Good evening to you.
Thank you, Ashish. Thanks for the introduction.
I remember after your training in internal medicine in Vellore, you had a very nice experience at mission hospitals in India. So I just wanted to know, at that point in time, did you treat cancers, particularly lung cancers, and what kind of inspired you to take up this journey?
Many years ago, during my mission hospital stint, and even before that, just the diagnosis was what we all had to do. And once we diagnose lung cancer, especially in the advanced state, we usually used to advise our patients to go home. And, used to tell them, eat well, live well, you've got few more months to live, and that's about it.
You have trained a lot in Australia, and so did you feel even that was an era even much before these targeted therapies were available? So did you feel like there was any difference between the way our patients were treated and what they were treated?
Oh, yeah, not really. By the time I went for training, most patients with advanced lung cancer would be offered a platinum doublet.
And then there was that paradigm shift of getting onto a targeted therapy. So which initially started with hematological cancer. So when did you get to know that there could be a possibility that even in solid tumors, molecular oncology would make an impact, and after that, it's kind of, did you really feel that one day it will be commonly used in our clinic in India?
No, at that time, we didn't really know about targeted therapy at all. And like you said, we were all thinking that, we would find that perfect chemotherapy combination that would be the answer. Yeah. By the time I came back to India, there was little, signs that there was this new drug called gefitinib. Those days they used to call it by some code name. But this drug called gefitinib was making some inroads in Japan and the USA, where some people, started talking about these great responses that came about with a tablet that had very little side effects and could be given orally. Based on these phase 2 trials, actually gefitinib was allowed by the FDA to be used in the US. But they mandated that you must have a phase 3 trial. And that is when, many of us got to taste gefitinib, okay? In what is called the ISIL trial, where we were all participants there. And interestingly, in India too, we saw quite dramatic effects. I, for example, remember one patient who had, brain mets which were treated with radiation, and somebody like that would hardly last 3 months. And here was this man, headmaster of a local school, with brain mets and an adenocarcinoma of the lung, who went well beyond a year on gefitinib. Found that we in the East had a much better response rate. And then subsequently only we learned about the mutations.
So, sir,
That's how. So this was a drug that came before we heard about the target.
And how easy or how difficult it was to set up this mutation testing? Because I remember, now we have the luxury of all the technology and all the platforms with a lot of pharma collaborations and private labs. But during those days, how did you go about developing these tests, molecular?
It was that was a difficult journey because even institutions like ours were reluctant to put in the money in a test like a PCR or something to get these mutational analysis.
Now we know that it's not only EGFR, and then there is so many different things. So like in today's, when you see somebody with a mutation positive lung cancer, what do you generally tell them? Like, I'm sure they're all frightened and they all have different questions. So how do you deal with them?
Yeah, so the moment people hear about lung cancer, they don't want to even wait for the mutation test. They want, desperately to start some treatment of the other. So it does take a little effort to, to explain to them about mutations, about the benefit of mutations, and the benefit of waiting for the test, when it comes. Many people start off empirically on the TKIs, but I personally don't believe that that's a very good way of starting. We now have evidence that chemotherapy plus a TKI may be quite good.
Sure. Now something similar, sir, right? Like you said, the initial trials were negative, and then because we didn't know a biomarker. So do you feel that in most of the solid cancers, whenever we see a negative trial, it could just be that we don't know in which patients does it work, especially now with the future being different combinations being tried, immunotherapy. And so what would, and also we always hear about positive trials, especially the pharma sponsored trials, and then the negative trials are hardly discussed. So what's the message here, like for younger people who are actually beginning their research journeys or beginning their career?
If you know a target and you know that that target is druggable, then that obviously leads to a positive trial, provided that the drug is not too toxic to be used in humans. And that's the issue. While, when you don't know the target and you just, kind of use a drug, you're actually using the drug more like a test to pick out those people who might have the target. Improving the population in which we use that specific drug is the way to go today. And I'm pretty sure that that's how science is going to go. Today we have artificial intelligence coming into medicine, and I'm pretty sure that you'll get a sample of blood that will get sent off for next generation sequencing or whatever is going to come after that, and we will get soon a computer telling us which particular drug can be used in that particular patient, irrespective of what we call the disease. The disease doesn't become so important. The question is what target that particular patient has. And then whether it's lung cancer or breast cancer or whatever cancer, if that particular target is available, then the drug is very likely to work. That's what we are seeing today. If you look at crizotinib, it is used in so many different malignancies.
I mean, do you think that India being producing generic drugs and the problem of access to these drugs, what do you think would be an ideal situation, and how we can go about it?
Yeah, so the usual excuse of having high costs for these drugs is that it costs a lot to develop medication, and that's partly because of the way that things are designed in this world, especially the clinical trials and the regulatory agencies, what they demand of us. I think the world will slowly go into a phase where this whole thing will become pragmatic, and even the regulators will realize that there are drugs that might actually benefit mankind without necessarily going into these costly ways of regulating it. And today we know, for example, India has requested most farmers to produce an India-specific price for their drugs. And we have gone a long way there. And I think that is a big success in India.
Sure. So thank you so much, sir. I mean, I'm sure these insights were so valuable to people who are just joining in, and we look forward to many such interactions in the future. Thank you.
Thank you, Ashish.
So thank you so much, Ashish sir and Raju sir. We'll move on to our next session. Our next expert is none other than Dr. Kumar Prabhash, medical oncologist from Mumbai. Over to you, sir. Kumar sir, would you like to share your screen, sir?
Just yes, if you can stop sharing.
Yeah, so you can share your screen, sir. Yeah.
Is it visible?
Not yet.
Yeah, yes, sir, it's visible now, sir.
Now visible?
So you can make it full screen, sir.
Yes, and I'm audible also?
Yes, sir, you're audible as well, sir. Perfect.
So, good evening, everyone. And I thank the organizers, especially Dr. Parikh sir, for giving me this opportunity for this lecture today. And my topic for presentation is liquid biopsy in lung cancer. And what I've tried to do is given a bit of a twist of what we do, and also try to compare a bit to give a hang of it, what we are looking for in future. So that you will get some comparison and some comments on the way liquid biopsy looks in lung cancer. Starting with liquid biopsy, what do we mean? We know that it means many things for many people. And what we try to do is we try to take things from, not from the tissue. Apart from that, wherever you get things from, and you can use that to do many kinds of analysis, and that's what gives you what we call liquid biopsy. And what you can see here, it can vary from CTC to cell-free DNA to exosomes, platelets, microRNA, so many of them. What we will be focusing today upon is we'll be restricting the discussion on cell-free tumor DNA, and that's what in today's time has impacted, and I'm sure we are going to see many more to come as the time goes by. So starting with the lung cancer, does it help in diagnosis? So many times we restrict ourselves only in mutation. We try to see, does it help in diagnosis? There are two papers in last World Lung Congress, and this was one of those papers where we tried to see that in blood, they had tried to analyze almost 8,000 immunogenic proteins by ELISA, not very tough test to do, and they tried to evaluate in early detection of lung cancer. What they found, if you use this along with CT scan as a screening tool, then the chances that if you have this intervention, the chances you're getting a late stage lung cancer is going to be 60% as compared 58.9% as compared to 73%. What it suggests that you detect early stage lung cancer more if you use this technology. Is there something else? Yes, someone tried to combine low-dose CT scan with blood microRNA. And does it help in reducing unnecessary low-dose CT scan repeat in this situation? That was the aim for this study. This was a prospectively randomized control trial, and what we can see here, that idea was to see that 3-year screening interval for double negative low-dose CT scan and microRNA. What it found, as far as the overall conclusion is concerned, that baseline blood microRNA and low-dose CT scan predicts low-risk patient with lower mortality. Low-risk patient also had higher, significantly higher in the subject with single positive and double positive tests. So if you have positive test in one, then they become in higher risk group. And also, lung cancer mortality also was significantly higher if you have these one of them being positive. And those patients who were negative for microRNA and low-dose CT scan at a baseline, then they did patient, if they didn't do a CT scan again, there was no detrimental effect on these patients as far as the outcome is concerned. What does it mean? You can avoid multiple CT scans, what we do in today's time in screening for these patients. So again, promising result in this setting. Now, how good is the liquid biopsy? That is the one of those question which always comes when we want to use in the clinic. Now here it was the routine regular mutations when they were compared for tissue and the liquid biopsy. The concordance was around 98% with 100% positive predictive value. In another study, it was 89%, suggesting that it is good. It is good to detect these patients, in liquid, in blood as compared to tissue in these patients, and we can give the treatment based on this technology. Now, how good is the similarity? This was the, and the primary endpoint was to identify that what you see in the blood and the tissue, and they put non-inferiority margin here, and they found again that yes, they were similar. If you do the mutation testing in liquid biopsy, you find in 21.3% as compared to 27.3%, comparing tissue versus cell-free DNA, meaning that yes, you find similar percentage of patients having mutations if you do these tests. This was our work which we did and published, where the concordance rate was around 96%, sensitivity was 90%, and that is something to remember. The concordance is good, but sensitivity ranges from 80% to 90% depending upon those mutations number, which we will be talking about in case there is a question, meaning that sometimes you do miss those mutations. But let us see, is there some other advantage? One of the issue remains, what is easy to do? Tissue biopsy, you require various of those technology and intervention and the manpower to do it. Liquid biopsy, if you have a phlebotomist and a good molecular biologist, you can get the report. Does it get reflected in the clinic if we focus on tissue biopsy and see what happens? If you do that, only 20% odd patients of lung cancer has the biomarker test when they meet their first oncology consultation, meaning that few weeks has passed when they would have had this test or the diagnosis. Now again, few weeks will pass when they will do these tests, and then you can start the treatment, knowing that good number of patients will have a decrease in the general condition in this time. So it again begs the question that should we be fixated with tissue biopsy? Now, in today's time, you have multiple mutations. Again, if you get fixated with the tissue, we want to do sequentially, then only around 18% of the patients, they have the whole gamut of the mutation done. Again, here you do have the advantage in the liquid biopsy, one-time blood, send it. If you have a good molecular biologist, they can do all these things in one go, and you can get the report in few days. We also try to see, does it happen in our clinic? Yes, almost 35% of the patients, we had to start treatment either because of their symptoms, or they're not willing to wait, or a doctor not willing to wait for the molecular test because patient was so symptomatic. So there is a good need that we can have early test, and again, this is filled by liquid biopsy. What happens in the repeat biopsy? In repeat biopsy, if we get stuck with the tissue, only 60% of the patient you get adequate tissue to do have molecular testing. And that becomes important again, that if you do liquid biopsy, you can overcome this, and majority of the patient can have this test, waiting the tissue biopsy in case if it comes negative. What does the NCCN suggest? It is not replacing tissue biopsy with liquid biopsy, but it does suggest, and I don't say that we should replace it, but it does suggest that yes, if you don't have a tissue, adequate tissue, then yes, one should think about liquid biopsy. If you get a positive result, it is as good as what you get in the tissue. Is it safe? Yes, it is safe. You only have to get the blood, but if you do a biopsy in the lung, good number of patients may have complications. Is it efficient in the time management? Yes, it appears that if you do cell-free DNA based testing, you get the report in 9 days as compared to 15 days where someone had analyzed it. And I'm sure all of us will agree, but we need to have a good lab which can give the report faster. Out of these, liquid biopsy and tissue biopsy, again, you have a lesser human resource required if you do a liquid biopsy, which is more cost effective. Utilizing cell-free DNA in addition to tissue increases the detection by 48%, and that highlighting that yes, you can do it may become cost effective if you do upfront. Can it be done in the remote area? And I took the remotest place, and yes, there also liquid biopsy can be done because you can collect the blood and you can send it, but tissue biopsy becomes a challenge. And I'll come to this. This is a real issue. I'll show you an example of it, which was done by one of my colleagues who is a student. In future, can we have MRD detection in lung cancer when you have such an effective treatment? I know that tissue biopsy won't help, but liquid biopsy, you have something which can be useful. Can we monitor them on regular basis? Again, tissue biopsy is a challenge, but liquid biopsy can be useful. And there are some interesting data coming from various quarters. We will have our own data getting presented soon in this situation. Can we leapfrog in India? Sometimes we have our mental block that we need to have the first one to available everywhere. Then we need to have the latest technology to go all over place in the country. But I think so telecom revolution suggests, no, it is not necessary. We can leapfrog with a better technology without adopting all the older technology to everyone. So meaning that adaptation can happen if we want to. I was coming to that. If you don't have a good radiologist and a good chest physician who can get you the tissue, it becomes a challenge. This is the paper from one of my colleagues from Patna, where it is not easy to get tissue biopsy. And we did have a multiple discussion with him, and he sends liquid biopsy to all patients because he doesn't get tissue in majority of the patients. Do we mean to say that if you are not able to get tissue in majority of the patient upfront, we shouldn't be doing liquid biopsy? No, that's not true. And he showed that doing this, he is able to manage those patients optimally in a tier 2, tier 3 city, as compared to if we keep waiting for a radiologist to get trained, radiologist to willing to do the biopsy, and then to do this tissue biopsy for these patients. So again, many times it does help in relatively smaller center, we can get this test done. So for liquid biopsy, it is similar to tissue biopsy with lesser sensitivity. It is less tedious, report is faster, it is less invasive, it requires less manpower than the tissue biopsy, and it can be done in remote place also. Some more caveat which we should remember. It can be challenging for early detection, which appears that it may be helpful in future, maybe not today, but some promising result. Presence of mutation in plasma does not establish that these mutations are coming from particular cancer. This is one of the challenges. So we don't know which cancer it is from. The absence of mutation in many of these situations doesn't mean that you don't have mutation, because as I said, sensitivity is a bit lesser than the tissue biopsy. So we should keep in mind, good test to do, but if it is negative, we should remember that we may do tissue biopsy subsequently. Liquid biopsy technology cannot detect the histological transformation. That becomes a challenge. So in today's time, tissue to be there. The analysis of the tumor tissue for DNA, RNA, and protein level. Cell-free DNA reflects the genome of dying tumor cell and not the existing tumor cell, and there is some question. I know it leads to treatment decision making, but in today's time, it looks, if it is positive, it is positive. It cannot provide exact information regarding origin of the tumor, and that we all agree that that's the limitation of this technology. Thank you so much. We'll be happy to take questions if any.
Great. Thank you very much, Kumar. There are a few questions. One of them was from Rajesh Jindal. He says that if the amount of tissue is less, can we obtain ctDNA from saliva and urine? If the yield is low, the volume will be high. Can we increase the volume, say volume of urine?
Sir, in the saliva and urine, people have tried to do it. At this moment, it has not been standardized. We also did a bit of a work on this. It will take some time, and I can see your point that in blood you require more blood. Here you can have more urine and get more cell-free DNA. But it will take some time. It will be coming shortly, but it will take some time. At this moment, noise is too much there.
Right, got it. Any other questions? Kashish, are there any other questions?
Sir, I think those are the questions for the session.
Okay, great. Thank you so much, Kumar. I'm sure people will think of more questions, and then we can send you by WhatsApp or email.
Thank you, sir. Thank you, sir.
Thank you so much, Kumar, sir. We'll move on to our next session. Our next session is a panel discussion. Our moderator is Dr. T. Raja, a medical oncologist from Chennai. His panelists are Dr. Jovita Martin, medical oncologist from Chennai, Dr. Mangesh Kamath, medical oncologist from Bangalore, Dr. Sandeep Batra, medical oncologist from New Delhi, Dr. Vivek Agarwal, medical oncologist from Kolkata, and Dr. Manoj Mahajan, medical oncologist from Udaipur. Over to you, Raja, sir.
Thank you so much, Kashish, and I sincerely thank my invite. Allow me to share my screen.
Yes, sir. Please go ahead, sir.
Thank you for this opportunity, Dr. Purvish. And moving on to the topic, sequencing of EGFR TKIs in EGFR positive non-small cell lung cancer. Why this topic is necessary? Probably because if you look at what has happened over the past 2 decades, there are several important studies that have come and established the role of several different TKIs that can work against the EGFR mutations. For example, in 2009, we were all excited with the IPASS data. Then came the Optimal in 2010. And then, came the Lux-Lung studies 3 and 6 for afatinib. That came in 2013. And then came the AURA trial in 2017, Archer and Flora. So a lot of trials, a lot of different, inputs. And then we are trying to now figure out how is the best way that we can make sense out of all these things. And I would refer you to one important study, one important paper published 2018, just end of 2018 by Professor Nicolas Girard from France. And he tried to address this question specifically, which tyrosine kinase inhibitor and when. So he kind of structured his paper this way. He asked the question, how do I select my right TKI to optimize my treatment? To look at the efficacy, safety, resistance, subsequent treatment, presence of brain mets. And then he tried to put his paper this way, Professor Girard. Evidence, one, is TKI or the standard upfront, or one of the best standards, can I say. Then evidence 2, that not all TKIs are equal. And then evidence 3 is biology drives the sequence. Evidence 4 is biological monitoring and what happens to those mutations. And finally, the sequence really adds to the survival. That's how he has come out. Now I'm going to ask these questions specifically about all these 5 different evidences that he is presenting. And I'm trying to ask the question to my panelists. We have very wonderful panelists. I'm just turning to Dr. Mangesh. The first question, EGFR TKIs are standard in first-line treatment of these mutated diseases. Mangesh, your comment on this as pertaining to the PFS advantage. Is this an established fact? What are your comments? I have put some data for you.
Thank you, sir, for the question. Yes, I definitely would like to believe that we would definitely want to use first and second generation TKIs versus chemotherapy across phase 3 trials. And now we also have data that we can combine the first generation TKIs with chemotherapy for some subsets of patients.
We come to that. I mean, combos are going to come a little later. So it is kind of established that, the first and second generation can provide longer PFS compared with chemotherapy. That is established. Now, can we extend that same comment to the newer drugs like dacometinib and osimertinib, Dr. Sandeep Batra?
It's across the board, first generation, second generation, third generation. The PFS improvement with TKIs vis-a-vis chemotherapy is there.
Then, the data gets a little bit deeper. There is something called common mutations, or let's say the intent to treat populations, and then DEL19, and then we have the L86. So
it
do you
depends.
think this holds true across all
So
these?
it holds true for the common mutations, but not for the uncommon mutations, for which second generation and third generation TKIs hold the key.
Okay, we'll come to that. And now I have put in the chart of the median PFS for all the first line EGFR TKI treatment. In this, I have included the first generation, second generation, and then I have gone on to include the Lux Lung and the Archer, the dacometinib, and the FLARA. So I'm coming to Dr. Vivek Agarwala. What is your comment on the PFS advantage of these trials? And again, there is also some more additional data as to how many of them went on to receive subsequent systemic treatment. Dr. Vivek Agarwala, your comments on the PFS achievements.
Yeah, so sir, traditionally we were only showing PFS advantages with the first line and the second line, and then later on, I guess it was first time with a combined analysis of the Lux lung studies that we could show that yes, they were also started to impact OS. And when you are starting your TKI vis-a-vis other systemic therapy started to make impact. And now with the recent dacometinib data and the FLORA data, we know that yes, it is very important to start TKI upfront to get the OS advantage also. Also, as you had clearly shown, sir, that the PFS advantage is also grown with the recent FLORA as well as the dacometinib data, showing that the PFS duration is somewhat longer when you go ahead with your third generation and second generation TKI.
Yes.
Also, the point that you made that subsequent systemic therapy. So if you look at the older trials, again, the patients who were receiving subsequent systemic therapy, the percentages were less, but now with the more effective treatment, the subsequent second line treatment and third line treatments are growing. So definitely, we see a great deal of improvement.
Vivek, from what you say, is there a clear winner as far as the PFS goes? If I am telling you to pick the number one or number two, would you want to do with this available published data?
Yeah, sir. If you ask me for exon 19 deletion, then probably I would pick osimertinib as a clear winner.
Okay. So now I'm turning to the OS factor. Dr. Manoj, I'm coming to you. Dr. Manoj, do you think there is an first-line EGFR TKIs versus chemo published phase 3 trials alluded here? Gefitinib, erlotinib, and afatinib data is presented here. Have they really provided OS advantage, Dr. Manoj?
No, sir. It has not clearly benefited versus chemotherapy. But second, as like earlier discussion, second line versus third line has definitely shown the data. There are some of the trials which are like putting only pointing towards exon 19, but that I guess that is again with the afatinib and subsequent generation like osimertinib.
But I have given you some median OS data from all the pertinent trials, Manoj. So you agree that there is an OS advantage. with the first line usage of these drugs or not? Dr. Jovita, your take on the overall survival advantage of the first line usage of these agents. Dr. Jovita.
Thank you for the question, sir. So happy to be a part of your session. Actually, as you rightly shared, I mean, it does give a good advantage. But my only take in this is that I'm a fan of using the second generation of afatinib for the basic reason that when I use that as the first line, I have 4 advantages. I just want to, enumerate them. One is afatinib is irreversibly binding. Second is it has a good CNS penetration. Third is it actually attenuates the T790M clones in such a manner that it can be very addressable and easily treatable later on when it develops. And I think I'm missing out on one more point. I guess it is.
Don't worry, we are going to come to all of these individually very soon. So it's very glad that you pointed out. Yes.
And also it has a very good coverage of the ERB factors. So that is why if we use afatinib followed by the osimertinib, I basically feel that it would be a good sequencing.
Okay. So Dr. Mangesh, coming back to you, Dr. Jovita just said about some of the factors why she would consider that afatinib is superior. So I'm now broadening the questions and saying that these are the TKIs that we are using at present, and this is the structure of the TKIs, all of them, and I've just put in the summary of their properties as far as their EGFR binding goes, reversible, irreversible, and CNS penetration and food effect and their metabolism. It is very clear that they are all not the same. So Dr. Mangesh, this question on all the TKIs are not equal. What is your comment on that, Dr. Mangesh?
Yes, sir. I definitely believe that all the TKIs are not the same for 3 reasons. One is that the first generation TKIs now, they are only now showing OS advantage when they are combined with anti-VEGF, number 1. Number 2, I would reserve tablets, drugs like afatinib for especially deletion 19. It has shown exceptional benefit with respect to even overall survival in the subset analysis. And osimertinib has shown very good CNS penetration, and also it covers the very dreaded T790M mutation. So they are not common. So it is actually an embarrassment of riches for us. And now with the new data coming about adding these TKIs with VEGF, with chemotherapy and all that, certainly the jury is out. But personally speaking, I have used osimertinib on quite a number of patients, and I am very happy with how it benefits the patients as well as the tolerability of the patient. I did not have tolerability issues with afatinib much either, and I am also happy with the Jeftin. So these are probably some of our individual choices through our personal experiences as well. Thank you.
Okay, Dr. Sandeep, talking about Mangesh touched about their tolerability and so on and so forth. That's also important. But then vis-a-vis their selectivity against the different mutations, spectrum of activity, I've given the IC50 of all these different drugs that we commonly use, gefitinib, afatinib. Osimertinib is very clear that the EGFR activity is not similar. But has that really translated into clinical trial outcome, Dr. Sandeep?
So I think going by Flora data, the use of osimertinib has clearly resulted in that what we are seeing in the chart that you are showing. And we don't have a direct comparison of afatinib with osimertinib, but afatinib when compared to chemotherapy or other TKIs has shown that advantage. So whatever is there in the lab is also translated onto the bench side with the improved results because of the individual characteristics of the TKIs.
So is that true for all of the TKIs that there is published?
No, second and third generation.
Second and third generation. So particularly with afatinib, clearly.
Afatinib and osimertinib.
And as you rightly said, yes. What about dacometinib, Dr. Vivek?
Sir, it is a new TKI. The data that is being shown is really impressive. And I am really looking forward to having more and more experience. But with so many options coming in, I really understand that probably it is going to be a difficult decision for all of us to which to choose. But I think, sir, osimertinib with the FLORA data really is a benchmark which is very difficult, for the other other TKI to reach. And I think unless you reach that benchmark, I don't see a reason why we shouldn't go for first line
We will
osimertinib.
come to that, Dr. Vivek, whether this is truly the benchmark or not. We'll come to that in a minute. Dr. Manoj, these are the FDA approvals as of now of various available TKIs, and vis-a-vis the different location of the EGFR mutations, 18, 19, 20, and 21. Again, at this juncture, if I say that, can you pick a winner? Can you do that, Dr. Manoj?
To certain extent, sir, we can have like biology driven when we say T79 mutation. So osimertinib is definitely a winner in this situation. In clinical practice scenario, when cost are concerns and uncommon mutations are there, the afatinib would be a would be favored amongst rest of the others. So I think there is definitely biology driven. We can have some choices.
Agreed.
Yes.
Dr. Jovita, now we are trying to address this question. Third evidence that Professor Girard presented: biology drives the sequence, touching on DEL19 versus L858R. Is there convincing data that these are two different diseases, Dr. Jovita?
So I wouldn't say they are two different diseases, sir, because I think incidence-wise, deletion 19 and L858 are together makes it around 40 plus 45 is around somewhere around 80% plus. But when it comes to an upfront first line of osimertinib, no matter what the FLORA trial says, the subgroup analysis shows some disadvantages. As in the people who are more than 65 years, they have not really benefited. And also we see that L858R has not benefited with osimertinib in the first line. And also we see that the resistance mechanism that happens right after we use the first line of OSI actually gets a little tricky, and it's very difficult to deal with those patients. And so we are left with very, very less agents, just chemotherapy alone, I would say, and the response is bad.
Okay, thank you. I have presented the PFS by various different options and the clear direct comparison between exon 19 deletion and the L858R. It looks as though they are not at least the same disease. You can see that both PFS and OS benefits of the published data seems to be not exactly identical and different. That can be elucidated with various trials. And again, the Lux Lung series and the Archer series, every one of that clearly show that these two are probably slightly different. Mangesh, I'm coming to you. And now you first touched upon, can we expand the, armamentarium by TKIs plus chemotherapy? So what did we achieve, and which patients specifically would you look at this kind of option, Dr. Mangesh?
So, sir, I was a part of one of the debates about osimertinib versus geftinib plus pemetrexed carboplatinum debate in the recently concluded ICON last year, in which I debated for osimertinib for the simple reason that osimertinib, according to me, is a very good drug with respect to its benefit on these patients, especially prevention of T790 and also brain metastasis. But one thing I would like to touch upon is it's not going to be utilized by everybody. So I definitely relegate the fact that TKS should be combined with chemotherapy in all patients, especially those who are in a very good performance status. Because across the board, all my fellow oncologists will agree that very rarely we get, it's not common for us to get all lung cancer patients who are going to be in a good general condition to undergo second line therapy. So I would definitely use my best armamentarium for treating metastatic lung cancers in the first line setting. So we have also seen with the Tata study that even there was a great benefit for patients with the combination of geftodotin and pemcarbo. Having used it on those patients whom I felt that there was whom I used it for a few patients now, I certainly believe that this combination is well tolerated. It does not lead to a lot of issues. We are almost getting the same number of side effects with the combination than we would have got with pemetrexed or carboplatin alone.
Thank you, Mangesh. I will then ask Sandeep. There is other way to go around. You have the VEGF inhibitors, bevacizumab data, and we also have the ramucirumab data. And where will you place them, Sandeep?
Placement vis-a-vis chemotherapy, right? TKI
Yes.
plus VEGF.
Chemo or first line choice. Where would you put these, EGFR, TKIs plus combo with VEGF inhibitors?
So I will put them behind the EGFR plus chemotherapy, because the OS data of the geftinib plus chemotherapy is much more impressive than the PFS benefit of the EGFR plus anti-VEGF.
Is there a patient profile that comes to you that you would think about when you want to use that? Nothing comes to mind. That is very important. You are answering the question by your silence.
Yeah.
Okay. Dr. Vivek, coming to you, is there a patient subset where you would want to consider in a known EGFR mutation patient that you want to consider immune checkpoint inhibitors? Dr. Vivek?
No, sir. I mean, if there is a known EGFR mutation, certainly not upfront.
Okay, look at this data. This is wild type and L858R and exon 19. There is a different response to the immune checkpoint inhibitors, and the immune checkpoint inhibitors are much better in producing response in the L858R as compared to the exon 19. So therefore, there is a tremendous argument that L858R mutations have a higher TMB value, and therefore immunotherapy may be an option. Again, there is a very provocative statement that L858R is a different disease, probably needs combination, probably needs dacometinib, so on and so forth. Anyway, we'll move on. Uncommon mutation. Everybody was interested in uncommon mutation. So I'll come to that. Dr. Manoj, uncommon mutations, when you see them, what comes to your mind, Dr. Manoj?
Upfront, sir, I was spoken. Afatinib would be the first choice because there is robust data for the afatinib, and like as compared to geftinib and erlotinib, afatinib would be the first choice in patients with the uncommon mutation.
I'm presenting the uncommon mutations here. So, there are uncommon mutations in exon 20 and exon 18, and also there are some uncommon mutations in exon 21 also. This is the exon 20 portfolio. Again, so many different mutations, and these are the studies that have documented response rates for the exon 20 insertions. And again, the osimertinib data on exon 20 insertions. And again, this is the osimertinib data response rate for uncommon mutations in exon 20, exon 18, and exon 21. So again, I have the afatinib data in the uncommon mutation. So are we all convinced that in uncommon mutation between osimertinib and afatinib, is there a choice, Dr. Jovita?
Actually, there could be a choice, as the first preference obviously is afatinib based, but some of the mutations might benefit with the afatinib low dose and chemotherapy, because some of the papers do say that. And the third option is immunotherapy. I think that would be a better choice in uncommon mutations.
Okay, immunotherapy in uncommon mutations. That's a statement. But afatinib has got enough data to support. Moving on to the other topics, Dr. Mangesh, would presence of brain met allow you to sequence differently?
Yes. So there are 2-3 factors which determine that. So One is if there is brain mets, then definitely I will seek the drugs which are going to have the highest CNS penetration. But at the same time, it also depend. The second thing is, even in brain mets, I would also like to see the type of mutation. So in fact, in my experience, I have seen a lot of brain mets coming with exon 18. So it would be actually wise to know the kind of mutation before we actually go ahead. And in this aspect, I would probably prefer afatinib. Actually, afatinib has probably got more sensitive mutation coverage across the board than even osimertinib right now. We can accept the T790M, but apart from that, we have got a lot of it's like a broad spectrum TKI for us. And if I'm using something like erlotinib or geftinib for that matter, definitely chemotherapy will also be my it will be my combination to go for.
Okay, okay, that's a different thought process. And coming to what we call monitoring and what happens to these mutations. So to Sandeep, this is the molecular mechanisms that evolved to produce resistance, different mutation spectrum in first and second generation TKI when the patient progresses. And if you look at something peculiar, if osimertinib were to be used in the first line or in the second line, as per the AURA trial and the FLORA trial, the mutations are totally different. So does that tell you how to sequence things, Dr. Sandeep?
So I will combine into the question the last speaker answered about the brain metastasis. So osimertinib has an advantage of better CNS penetration as well as taking care of the mutations that develop in future. So which are much different than with the first or second generation TKIs. So that's why osimertinib would be my preference for using in patient, especially with or without CNS metastasis in the first line, because the development of mutations is subtle with the presence of osimertinib being there.
Fine. So that is a good take. And coming to the last part of the evidence that Professor Girard presented, sequence makes survival. He says that is a real advantage in survival. That is his take. And let's examine what he is trying to say. And this is the kind of sequence that he is trying to present. Dr. Vivek Agarwal. This is a general sequence. If you have a T790 upfront, think about osimertinib. Otherwise, any of the sensitizing mutations, you have the choice on progression mechanisms, and then T790 plus minus you choose. Do you agree on this, Dr. Vivek?
Yeah, very much. I do agree. Definitely, chemotherapy also features in there that we should not forget. One thing is that T790M, I mean osimertinib upfront, we are all worried about what we are going to give in second line and third line and the responses. So that is a worry, and that is a reason for many of us not starting osimertinib upfront. But I think the data regarding sequencing of agents post osimertinib is evolving, and probably very soon we will have our answers. But regular monitoring, at least liquid biopsy, is a must. And as you clearly showed that the kind of mutations and changes that happen post osimertinib is definitely different than the ones that happen the other agents. So we got to keep in mind, and then think more about combination chemotherapy and combination with other agents which are targeting MET, targeting BRAF, and of course immunotherapy. Somebody mentioned immunotherapy. Also, we should not forget the lung 7 data of weekly paclitaxel plus afatinib. So I have used that in progression in many patients, and that has also been effective for a few of my patients.
Thank you, Vivek. And Dr. Manoj, coming to you, how will you sequence after you have picked the choice of, TKI plus chemo upfront, or you have used osimertinib upfront? Do you have a strategy in mind, Dr. Manoj? Because sequence seems to be the key, everybody says. And do you agree or you don't agree, Dr. Manoj?
Yes, definitely, sir. Sequencing is the key, and as the most of the data is showing, OS benefit only when we are sequencing in a right manner. Like the mention in the earlier, afatinib followed by osimertinib has also good data. Osimertinib followed by newer data, which can, like, now we are not available. There is no much data, but if it follows, so that may add the best options available. And even the first generation plus chemotherapy has also good data. So depending on the patient's profile, toxicity profile, and safety efficacy, I think we can have 2-3 options upfront without T790 mutation. If it is T790 mutation, I think osimertinib would be the obvious choice.
Yeah, sequencing seems to be key. There are several things that are important. How many of them really get the second line? And if you look at simply this profile, Lux-Lung data outcome, this is the OS with patients who have a limited access to subsequent osimertinib, then you have something like a 33 months. But if you have a well confirmed access to T790 mutation and the osimertinib as shown in the geotag, you can reach up to 41 months. So you can achieve something more. And again, this is the FLORA trial data that showed who received what. So coming to the last question, Dr. Jovita, do you think sequence is the key? Is there enough evidence?
Sir, absolutely. I would agree with you on this. And the fact that the geotag and the real world evidence has shown that afatinib, first line followed by osimertinib, has given us a good head of advantage. I also want to highlight the fact that the mutation C797S, which could eventually happen after the osimertinib exposure, is what is going to pose a lot of problem. If it is going to be cis, then we don't have treatment at all. If we have a trans, then we can actually use a first generation and the third generation put together. And if we have a wild type, then obviously we can give chemotherapy, or first generation, second generation also will be, can be given. So thank you so much for this opportunity, sir.
Thank you, Dr. Jovita. And what I have done is, I have tried to say, give in the given time, there are various ways to look at what do we do. And it looks like you need to not think about one line, you need to visualize that there are going to be multiple lines, sequencing, and all that comes into play. There are various data points based on which you're going to choose. So it's not simple anymore, but it is getting exciting. That's what I can say. There could be various takes, there could be various opinions, but my panelists have presented their original thought process. And that's what is the take home from this panel. Thank you, organizers. Thank you for this opportunity.
Thank you so much, sir. Thank you to all the panelists for the wonderful session. We'll move on to our next panel discussion. Our moderator is Dr. Senthil Rajappa, medical oncologist from Hyderabad. His panelists are Dr. Shirish Alurkar, medical oncologist from Ahmedabad, Dr. Tushar Patil, medical oncologist from Pune, Dr. Sandeep Goyal, medical oncologist from Mumbai, Dr. Prashant Mehta, medical oncologist from New Delhi, and Dr. Rajiv Vijay Kumar, medical oncologist from Bangalore. Over to you, Senthil, sir.
Thank you so much, Kashish, and thank you, organizers, for asking me to moderate this panel that is titled Uncommon Tip 1. So you've got a couple of more uncommon tips coming up. And the title of this panel is Managing Patients with the Uncommon EGFR Mutations. So let's start with this case. This is a 70-year-old smoker, male, diabetes, hypertension, both controlled with cough and breathlessness of 4 months. Performance status always difficult, so that's why I've said 1.5, neither 1 nor 2. The clinical examination was unremarkable. This is the PET CT that you're seeing on the screen. There's a pleural-based mass in the left lung, diffuse miliary nodules, both lungs, mediastinal lymph nodes, liver, plenty of disease all over the place. He had a brain scan at the time of diagnosis, which shows small vessel ischemia. The biopsy from that pleural-based mass is an adenocarcinoma, TTF1 that's positive, showing that it's a primary in the lung. So let me start with Shirish. Shirish, what is it that you do routinely today in your practice? Is it NGS lung panel, or you still do sequential testing?
In most of the cases, it will be sequential testing. NGS is difficult to really, execute because of the cost factor and accessibility.
Right. Tushar?
Tushar, sir, you'll have to unmute your mic.
So Am I audible, sir?
Yes.
Yeah. So we are doing at least 5 basic panels: EGFR, ALK, ROS, PDL1, and BRAF testing at least.
What technique?
NGS technique.
NGS. So everybody in your in your hospital gets an NGS. Is that correct, or most of them?
Yes, sir. Yes, sir. So 10 working days is the time required. 10 to 12
Excellent.
days. So
Sandeep.
So we do EGFR, ALK, ROS, PDL1 for all the patients.
Okay.
And we don't use NGS
okay.
as of now.
Right. Okay, Rajiv, and then Prashant. Quickly numbers, and then we'll move to the next one. Rajiv?
I've done only one patient direct NGS, and that patient, it turned out to be ALK negative. When I did it on immunohistochemistry, it came out positive. So after which I've chosen to stick to standard, do regular
Your sequential
and then
testing.
IHC.
Okay, so you've got a non-believer here. Prashant, last word for you.
So, I also don't do NGS upfront. I do IHC for ALK, ROS1, PDL1, and EGFR by PCR, and it's sent on the IDELA platform. So it takes me around 3-4 days to get all the results.
Very good, Prashant. So though all of us would like to do a very standard NGS lung panel, the reality is that most of us are not able to do it today for various reasons: logistics, costs, turnaround time, and so on and so forth. But at least the basic mutations or amplifications we need to test. So let me start with Sandeep. In this patient whose performance status 1.5, 70-year-old, plenty of disease all over the place, in your hospital setting, would you wait or start chemotherapy?
So normally the results of the test are available in 7 to 8 days, usually. The thing is, it all depends on if the current symptoms are because of the disease and he's ill because of that, then obviously I would go ahead and start the chemo and then, see how things are. But and in this case, I think he's not well because of the disease,
Yes.
This is what I feel.
Yes.
So I would be more inclined to start him on the treatment, because sometimes the labs do take more time as well.
Correct.
So rather than waiting, and you may get the results in differential time frames, like you may get the EGFR last, you may get ALK first. And so I think in this patient, I would be more inclined to start the treatment sooner rather than later.
Right. Anybody on the panel has got a difference of opinion? Rajiv, Sandeep has done. Sirish, Tushar, Prashant?
No, sir. No, sir. It's
no, all of you
symptomatic,
would
so
start.
may need
Okay,
treatment.
excellent.
The chemotherapy that I would choose to start probably would be weekly paclitaxel carboplatin if he's a bit sick.
Okay.
Else, I will stick to the if it's come back, I'd go with PEMCARB.
PEM-carbo or weekly paclitaxel carboplatin. All right, Rajiv, that's perfectly all right. Okay, let's start with Rajiv again then. Why is it important to know about uncommon mutations, Rajiv? Uncommon EGFR mutations.
It's, the uncommon mutations, we know that the initial part to get the disease under control, that's the important time frame. If we are probably giving him a gefitinib or an erlotinib, and then the disease will not come under control, he will progress, and then he'll be too sick to receive either chemotherapy or the osimertinib or any other drug. So it's important for us to know the uncommon mutations upfront.
So that you can choose your drug, is that correct?
True.
Yes.
And so that he will be able to receive therapy. Otherwise, he might not be able to, if I give him a gefitinib or erlotinib upfront, and if it is not sensitive, if that particular uncommon mutation is not sensitive, then he may actually progress on that.
Correct. I understand. That's why. So you want to know the mutation because you want to choose the most appropriate drug. That's my understanding of your explanation. So Sirish, in your PCR that you do you routinely look for uncommon EGFR mutations? Do you check, do you check the technique and what they are actually looking for, Sirish? Because that's something that all of us don't go to the lab and check. So that's the reason why I'm asking.
I don't go to the lab, and we don't do it routinely.
Okay, so you don't.
Commonly, I don't look for the uncommon mutations.
Commonly, you don't look for the uncommon. Prashant, commonly you look?
Yeah, so the PCR which I do does look for the uncommon mutations as well. So I do it for 3 reasons actually. I'd like to elucidate.
Go ahead, Prashant.
So in the first line, because the uncommon mutations also, some of these are actually a little sensitive to EGFR TKIs, not albeit as much as the common ones, but they are. So in the first line, when I have started chemotherapy, I would think of combining with chemotherapy in some of the patients. Okay. Also in the second line, I'll have options when when the patient has progressed after chemotherapy. This is the second reason. And the third reason is also there is some hint that the IO drugs they are less effective in patients who have even the rarer mutations, but not as much to the extent as the common ones. But even with uncommon mutations, the sensitivity is lower than what the usual unmutated patients have. So these three reasons.
Great. So it's both prognostic and predictive. Prognostic because, as you rightly said, some of these patients have poorer outcomes with the conventional therapies. It's predictive because you want to choose your therapies based on that, as Rajiv said. So this is just a snapshot of uncommon mutations on your left. So that pie chart in the upper half shows that these are the various things that you can get. So let's broadly classify them into three groups. One is the T790M, which we will not talk about today except at the end. The other is exon 20 insertions. Okay, so T790M mutation, the other is exon 20 insertions, and then the rest of them all. And the rest of them all can be either major uncommon or compound mutations, which means you've got more than one EGFR mutation that you're seeing on this report. So it could be so many of these varieties. Now, when you come to the major uncommon, or you could also call them as the common uncommon, you've got these three. Please remember these numbers because these are very, very important when you're reading a report that's containing an uncommon mutation. So that's G719X. X stands for whatever substitution amino acid you get there. The L861Q and the 8768. I know it's difficult, but over a period of time, keep looking at these numbers and names so that you will become familiar. All right, and as we go by, we'll understand why. Okay, so we did PCR. So this is 2017. We moved to NGS now, fortunately, in our hospital. This is 2017. We did PCR and we got a G719X mutation in this particular patient. So let me start with Sandeep. Sandeep, what are your treatment options for this patient? So this is a major uncommon mutation that constitutes 40% of all uncommon mutations. Let me remind you, this is a 70-year-old PS 1.5 high burden disease. We decided to wait because the patient did not want chemotherapy.
Okay. So the thing is that there is, these uncommon mutations, we are not sure whether they will surely not respond to your routine TKIs.
Correct.
There is
so what would you do here? What would you do here?
So in these cases, I would prefer to go ahead with afatinib rather than the routine gefitinib or erlotinib, or other option is I would use osimertinib. So these are the two options I have. If the patient is able to afford osimertinib, I would go with that, or I would use afatinib.
Okay, so 70-year-old PS 1.5 high burden disease. Let me come to Sirish. Sirish, what's your choice of the four that I've listed here?
Yeah, my first choice would be the second generation afatinib. And maybe if the patient can later on afford, then maybe osimertinib. Otherwise, afatinib.
Afatinib. So 70-year-old PS 1.5 is afatinib an easy drug to use, Sirish?
Not really, but yes, some patients do get over with it. Yes, they tolerate
so what
quite well.
dose would you start if you decided to start afatinib in this patient? 20 milligram, 30 milligram, 40 milligram?
I start with 30.
You would start with 30. That's what most of us would do. In fact, if it's 65 plus, I sometimes start with even 20 if I see that the patient is a little frail. Rajiv, you agree with Sirish that you should start with afatinib and probably at a lower dose?
Yes, sir. The last time when I did afatinib in a 75-year-old male, and he had torrential diarrhea, and then after the expired after that. So after that, it's once bitten, twice shy. So hence after that, it's like now it's only 20 or 30 milligrams. I probably start with 20 milligrams. Either that or osimertinib upfront.
Osimertinib upfront. Great, good idea. Prashant, your thoughts?
So I also start with a lower dose. Although in my first patient, when I started using afatinib, that was about five years back. The first patient, I published it also. He had progressed after Erlo and Jeff, and I started on 40. He was PS3 or so, but he did not have toxicity. But I understand that it is a toxic drug, so starting on the lower dose is fine.
Correct. Yeah. Sometimes chemotherapy is easier than afatinib is what I feel.
Yeah. And one thing I missed that point. Did the patient say that he does not want chemotherapy?
Yes, he did not want chemotherapy.
Okay, then
you think chemotherapy would have been a better choice? Because I'm putting up this Kaplan-Meier in front of you.
I think so.
Great. So we'll come to. I'm glad you made that point.
Rarer subtypes, yes.
Yes, I'm glad you made that point. So this is analysis from the Lux Lung 2, 3, and 6. The PFS seems to be a little better for afatinib, though these are not statistically powered to be compared. But if you look at the right side, look at the difference in terms of overall survival for chemotherapy and the group 2, the group 1, which is the group that we are interested in at this point in time, there's a huge difference in terms of overall survival. So Prashant, you think your point is actually exemplified by this Kaplan-Meier that I'm showing you here?
Yeah, so I agree that, in such a situation, in fact, in the first patient I encountered a G719X, I started afatinib. After reviewing the literature, he failed on afatinib, did very poorly, very poorly.
Okay.
So after that, I have not started first line AFA on anyone with G79X. Although I have not come across it too frequently. So, yeah. It's a yeah.
Tushar, does this curve tell you that chemotherapy might actually be a better choice, or you want to stick to afatinib? What is it that you want to do, Tushar?
Probably titrated chemotherapy as per the PS would be a better choice in that case.
Okay. So we are kind of divided. So you're getting tempted into whatever I'm putting up there. That's fine. That's the intent. So the point is that things are not very clear. That's the point I want to drive home. There is data to show that in these patients, chemotherapy might actually be better, because these patients can actually fail early, deteriorate fast, and may not be able to take another line of treatment at all. So in such situations, chemotherapy is the best thing to do whenever you are in doubt. But if you're very confident about managing that mutation and that patient with afatinib or osimertinib or whatever that might also be a great choice in that patient. Okay, so that's the point. So it's a common, uncommon, or a major uncommon mutation. So there's data for afatinib, there's data for osimertinib, there's data with chemotherapy. Now this is another patient. This is 2018. So this patient has a G719X and an S768I. So another twister there. Tushar, let me start with you. What would you do for a patient like this? First is, what is the connotation of having a double uncommon major mutation? Is it any different from the previous patient that we saw, or is it the same from your thought process?
I think if we are taking these 3 mutations which are common in the uncommon mutations, so probably they are the most frequent occurring, and the literature does say that they are still sensitive to second line or third line TK. So
do these patients do better than the single mutation ones, or do these patients do worse, Tushar? There's no big time data, but with whatever data that is available.
I don't have any idea about this.
Any thoughts on for anybody in the panel? Sirish, Rajiv, Sandeep, Prashant, at least intuitively, what would you think?
So my feeling is that they do better, the complex.
We initially think like the complex karyotype we haven't looked.
Rajiv, we have lost you. I think you're Prashant, please go ahead.
Yeah.
I am just aware of S768I. It is seen with some of the common mutations as well as like a co-mutation.
Yes, you're absolutely correct.
And when that happens, they do better.
Okay, when that happens, they do better. So this is another lovely data that was presented early this year. Nearly 700 patients with uncommon mutations. Don't have to, strain your eyes really. You see that compound containing major uncommon mutation. That seems to be having the longest time to treatment failure. Again, these are not statistically powered comparisons, but numerically, it looks to be that if you have a compound mutation, which means 2 mutations, and both of them are major uncommon mutations, their time to treatment failure seems to be at least numerically longer compared to the single mutations. What would all of us think in general? The more the mutations, the more the genetic instability and the worse that they are likely to do. But very interestingly, surprisingly so, here there is data to show that if you have 2 major uncommon mutations consisting a compound mutation, the outcome seems to be actually numerically a little better, or at least same compared to single mutations here. So I think that was a very important understanding of this.
This was with TKIs or with chemotherapy?
This is with afatinib. This is with afatinib, Tushar. 700 patients are, data collated from various studies, real-world data, retrospective studies on afatinib. All this is on afatinib. So we come to another one of our recent patients. Now, with the advent of NGS, and we are doing more NGS, we are finding many more of this. So, Prashant, you did speak about this entity, wherein you've got an L858R and the G709L. What would be your choice of therapy for this patient? And I've just highlighted this variant allele frequency as part of this NGS report. This is done in our hospital. Does this percentage WAF really make any sense for you to choose your TKI or not?
Yes, the VAF does make sense to me. And in this patient, the L858R VAF is pretty high, 36%. So I would go with targeting this one.
Okay, so how would you target?
Mutation. So upfront, I am still utilizing the, either Geftinib or Lotinib or maybe Afatinib, but not moved on to Osimertinib upfront as of now. I am not convinced. So
Is it okay?
Most are actually.
Okay, in general, you have not moved on to Osimertinib.
No, in general, I have not. No.
Okay, and it's not because of the L858R subset analysis in the FLORA study. That's not the reason for it. In general, you've not moved.
In general, I have not. No.
Excellent. Sandeep?
Yeah, so in contrary to what Prashant was saying, I have moved on to Osimertinib first line.
Okay.
So that is what my preference is, because I feel as of now, my duty is to give the best first and option to the patient,
Great.
which is
So in this patient, you're going to do Osimertinib?
Well, either Afatinib or Osimertinib, that's what.
Okay, Afatinib or Osimertinib. What would be your choice and the patient can afford?
I would go with Osimertinib. Yeah.
You would go with Osimertinib. So that uncommon mutation that is sitting here has not had a major bearing on your decision making. Is that correct?
So, nobody is for chemotherapy and Geftinib.
Okay, nobody is for this because the Kumar.
I am for that. I am for that.
Okay. Very good. You're for that. So 5% of patients in Kumar's trial actually had patients with uncommon mutation. So Prashant is not wrong in choosing chemotherapy plus Geftinib in a patient like this. Rajiv, would you agree with Prashant?
I would go for chemotherapy because like I mentioned earlier, if the patient worsens, I might lose time. So I might as well go for chemotherapy, get the disease into control,
we've got
then
this
put him on
report.
Afatinib subsequently.
Rajiv, don't misunderstand what I'm saying. This is an individual patient. What will determine what TKI you will use? Is it the uncommon mutation or the common mutation? Does the variant allele frequency have a bearing on your decision? That's the question. It's not, forget our 70-year-old for a moment.
All right.
What would be your choice?
This is, I don't have a clear-cut answer, but I would probably err on using Afatinib.
You would err on using
almost correct.
Okay.
By using Afatinib.
You would be almost correct on using a lower dose titrated Afatinib. Very good. So the answer to that question is, let me tell you another thing, that nobody knows the perfect answer to any question that I'm asking, because I try to look into the literature to how to manage this specifically. There's some data to say that if there is a common mutation, which is L858R, then that should actually determine which TKI you should be using. So in this, if you even use Gefitinib and Erlotinib, you're not totally wrong. So that's the point I'm trying to make. And that's the reason why I have showed you this as an example. As Prashant said, though all of us are tempted to look at that variant allele frequency, we are not very clear as to whether that should dictate the TKI that we are using in a clinical situation like this. But yes, I do agree with Prashant that if you don't have anything else to fall back upon to make your choice, it is the variant allele frequency that you might actually take to make a decision regarding which is the TKI. So in this case, any one of the TKIs that we use in day-to-day practice, starting from Gefitinib, also might be one of the possibilities that you can use. No clear straight answer there. Let's come to this uncommon mutation, right? So this is exon 20, and that's a very complicated looking mutation that is described in this NGS report. So let me go to Tushar. Tushar, what is your choice of treatment for this patient? This is nothing to do with the 70-year-old again.
So I think second generation or third generation TKI.
Second generation or a third generation. So this is a substitution in exon 20, Tushar. So is an exon 20 unanimously a bad one to have, or is this a different one compared to the exon 20 insertions that we started with? In terms of the biology and the prognosis, is an exon 20 insertion same as an exon 20 substitution?
I think this exon 20 insertions would be a little better.
Exon 20 insertions would be a little better. No, it's actually the other way.
No,
around.
it's opposite. Actually,
it's the opposite. Sandeep is correct. Sandeep, can you expand, Sandeep?
So basically, exon 20 insertions and T7 and TM, they are more of a lack of response to the EGFR TKIs.
Absolutely.
There's one, although if I'm not mistaken, there's one insertion which is A763, something like that, which which has shown response.
Excellent.
So that
Good
is the
point.
only one which I think has showing some response. The others are more of lack of response.
Absolutely right, Sandeep. We are coming to that mutation a little later during this panel. So, as Sandeep rightly pointed out, exon 20 insertions are bad. Not all other exon 20 mutations, because this is a Kaplan-Meier projection again from the same article. Look at the time to treatment failure with afatinib here. Exon 20 insertions, it's 4.2 months. Others, which is where our mutation actually comes, is 4.5 months, which is not too great with afatinib. T790M, as all of us would expect, is bad. But look at what happens with the compound, it is 14.7 months. So when you're looking at an uncommon mutations, the reason why I started by saying learn the three major uncommon mutations is because they have a slightly different biology compared to all the other. For your information, there are 600 EGFR mutations characterized so far. So it's not 1, 10, 20, 25. There are 600 mutations, and over time we should learn. This is a poster that was presented at ESMO 2020. The gray bar is the uncommon mutations. The overall response rate is actually great with the afatinib, right? This is in Asian patients. This is in non-Asian patients, 80% and 60%, big numbers. But when it comes to the duration of response, look at what happens. It kind of drops down significantly. So if you have an uncommon mutation, the outcome for that patient with even the second generation TKI, which is afatinib, is not great. We don't have much data on osimertinib at all in this particular setting. So you have a major uncommon mutation, great, straightforward, afatinib is the choice. Osimertinib has also got some data. You have the uncommon mutations, the one that I showed you, where the outcome is likely to be poor. All exon 20 is not bad. Exon 20 insertion is bad. Other substitutions or point mutations in exon 20 is not so bad. You can still target it with one of the TKIs that are available. Okay, the same patient, 70-year-old, right? 3 brain metastases, 1 in the frontal cortex, 2 in the parietal cortex. The largest is 1.2 centimeter. He's asymptomatic for these brain metastases. What is your choice in this particular patient, Prashant? Afatinib, chemotherapy plus osimertinib, erlotinib, SBRT plus one of the above.
So I would do SBRT definitely
Okay.
in this setting and use any of these, drugs. I probably either afatinib probably. Yeah.
Okay, so if I said osimertinib has got activity in this particular mutation and it also acts in the brain, would it be reasonable to use that, Prashant?
It is certainly reasonable. It's fine.
It is certainly reasonable. Sandeep, what would you do?
I would just give osimertinib to this patient. I would not even use SBRT because it's asymptomatic.
Okay.
So give osimertinib for some time, see how things are, and then take it from there.
Okay, so you're saying get a TKI that has got better brain penetration and also one that acts on one of these uncommon mutations. Makes a lot of sense. Sirish, does that impress you? Are you agreeing to that?
Sorry, what has the patient received first line?
Nothing. TKI naive, treatment naive patient.
Yeah, because of the brain mets, then the data definitely supports osimertinib.
Okay, so that's the important point that I wanted to drive, that afatinib must be having the largest data available for these uncommon mutations, but when it comes to some specific situations, osimertinib might actually take the cake because of its brain penetration. So remember that the response rate is there for all the TKIs with these uncommon mutations. The problem is with the progression-free survival and of course the overall survival, which kind of start dwindling down and dropping. This is another patient. We don't have enough time, but this is insertion. Sandeep, you were talking about insertions. Is it important to know insertions? And are there insertions which are quite fine? You spoke about some sensitive. Is that fine?
Yeah. So most of the insertion, the exon, like if it's exon 20 insertions, most of them are bad. Most of them are bad.
Yes.
Except there's one insertion which I know is A763, 764 insertion. And that has shown that is responsive. So not all, but that's very rare. It's a very rare insertion. I've never seen. I've just read about it.
Correct.
So I don't know if anybody has experience of seeing that insertion, but that is shown response. Yeah.
So the insertions that you're talking about, I have listed at the bottom of the slides, Sandeep. So those are the two insertions that are actually sensitive to the available TKIs as of now. Otherwise, most people think that the standard for exon 20 insertion should be chemotherapy. The other important thing is that there is some small data of 25 patients on double dose osimertinib, where the response rate is around some 30% or 35%, and the PFS is actually a quite impressive 9 months, but that's a very small data set. So the standard for exon 20 insertion at this point in time should be chemotherapy. Amivantamab is not yet available in the market for use. Posiortinib has been taken off, so that's not typically a drug that we should be looking for when you get exon 20 insertions. There's another mobocertinib which is being tried for exon 20 insertion. So these are the 3 drugs that one should be looking for. So that's about exon 20 insertions. Last, I just want a yes/no answer. 36-year-old non-smoker with squamous cell carcinoma, liquid biopsy, T790M mutation. Prasant, osimertinib or chemotherapy? Squamous cell carcinoma, T790M.
So I'm okay with osimertinib in this situation.
You're okay with osimertinib in this. Anybody for chemotherapy?
Chemotherapy. Osimertinib will probably work for 2 months, and then after it's going to fall flat.
Why
I've had
do
the
you
same
say
similar
that?
kind of case.
Okay.
Patient didn't do well after 2 months.
So you don't believe that osimertinib is a good drug for T790M, Rajiv?
Sir, with squamous cell background, that's going to be.
Okay, you're saying the squamous T790M is different from the adeno T790M. Is that correct?
Yes, sir.
Okay, Sirish, do you think that we missed the adeno component on the true-cut biopsy, and the liquid biopsy actually picked it up from the adeno? I don't know. I'm just asking you this question. Because squamous to have a T790M is so rare. Do you think it was adeno?
It's very rare. I really don't know how to interpret this data. But traditionally, I will go for chemotherapy.
Traditionally, you would go for chemotherapy. So an easy guide to understand what to do is, I spoke about the 700 patient data that, was published earlier this year. So this is being now created as a database by the Boehringer Ingelheim people. And this is www.uncommonegfrmutations.com. So if you have a problem trying to fit what to do with your patient, you can go to this website. You can actually type your mutation that you have gotten in this space, and this is what you would get when you do that. It will get you what this mutation, has it been reported so far? Is it novel? What is the response and data that is available with the TKIs that we are using routinely for this afatinib and the other things, so that this will help you to a certain extent regarding what is the choice that you have to make. But ultimately, it's not so easy to deal with these uncommon mutations. But as we keep doing more and more NGS, we are going to get into trouble more often with these uncommon mutations, because there isn't large volumes of data as far as uncommon mutations is concerned. So this is a ready reckoner and a guide that's been created by Boehringer Ingelheim. But who are friends of this gentleman, please call this gentleman and he will tell you the correct answer as to what is to be done for patients with uncommon mutations. Thank you so much, all of you. I think we've wound up in time, and I'll hand it over back to the organizers. Thank you so much.
Thank you. Thank you very much.
Thank you so much, sir, for the wonderful session, and thank you to all the panelists. We'll move to the next part of the program. Our next speaker is Dr. Anand Pathak, Senior Medical Oncologist from Nagpur. Over to you, sir.
Good evening. So can you see my screen?
Not yet, sir.
Okay. Now?
Still no, sir.
Okay. Now?
Yes, sir. Now we can see that you've started the screen sharing. Yes, sir.
All right. So thank you very much, and it's nice to see everybody. Thank you, Purvish, seeing you after a long time. And that was really interesting to see Dr. Senthil navigating the panel discussion on a very difficult topic of uncommon EGFR mutations. My topic is NGS in uncommon EGFR mutations. So, you got a glimpse of what these mutations are, and they are very heterogeneous. And Senthil rightly described that they could be single mutations, they could be complex mutations, they could be insertions, they could be substitution, they could be deletion, they could be compound mutations. And probably we are just beginning to learn to interpret and see what we can do about them. So, when we have an EGFR test report and a mutation is found, as clinicians, we want to know whether we should treat this patient with EGFR TKI which are available, or whether this patient would fail to respond. Now, most of the classic EGFR mutations that we see, the L858R and the exon 90 deletion, are extremely sensitive. Very few of the uncommon mutations that Senthil described are sensitive. Some of them are in fact resistant. And therefore, we must know this fact whether they are going to be sensitive or resistant. We do not know the exact incidence of these mutations. From the available literature, I could find out that the frequency of these mutations could be from 4 to 20%. And one thing is sure, that they are being increasingly reported as we use more and more NGS. So now we are all aware about various methods that we commonly use to test for biomarkers in advanced lung cancer. Now NGS is maturing very rapidly, and there is increasing use of NGS across various centers in India. I'll begin by quoting this paper from our colleagues of biomarker testing to do a comprehensive paneling of patients to study the mutational landscape. And what in their study they found that it has an analytical validity, and it compares equally well with a single gene testing. And in their study of 100 patients where they did upfront NGS, they could pick up 4 uncommon mutations. And some of these, the four these rare mutations were so rare that they were not described. And this was the plot of their uncommon mutations. And these mutations we do not know as yet. We'll have to refer to that website which Senthil described to find out how these mutations would fare in the clinic. What is more important, in addition to know whether a particular mutation is sensitive or resistant, there are frequently other coexisting mutations that are found if you use NGS. Now, we do not know always the significance of these coexisting mutations, but there is increasing evidence that some of these mutations might be representative of resistance pathways, such as the PIK3CA or the RAS pathway or the TP53 pathway. And in case you have a patient who has an EGFR mutation plus a coexisting mutation in any one of the resistant pathway, you know for sure that the EGFR TKI therapy that you use might fail. So when you interpret such a report or any other report which Senthil showed, we go to the list of, go to the website and find out if it is simply sensitive or resistant. But that may not be always so, because we do not know whether the mutation in question is a driver mutation or not. So another study which was published in BMC Cancer recently was a novel way to pick up uncommon mutation by doing a molecular barcoding system in the NGS panel that they used. And with that molecular barcoding system, they could increase their pickup rate of uncommon mutations to almost about 10%. And they found that with certain mutations like the G7919X, the incidence of compound mutations were much higher than other mutations. And they concluded that uncovering the true genotype using an accurate NGS platform will enable the development of proper therapeutic strategies for NSCLC. Now, this is another study done by Italian investigator, and found it very interesting. What they did was they did a multicentric studies. 3 or 4 labs in Italy collaborated in the study, and they used next generation sequencing of lung cancer EGFR exons 18 to 21, and they compared it with Sanger sequencing. And they studied almost 80 samples. Now we know that tissue is always an issue, and Kumar alluded to it. And then it's not easy to get an adequate tissue for all the tests that we need to carry out. And this was the focus of this study. They picked up patients who had small biopsies from different sites, somewhere from primary, somewhere from metastatic site. And they also had patients who had cytological samples. And they compared NGS with Sanger sequencing. And what they found, that the pickup rate of all mutations, including other uncommon mutations, was much higher by NGS as compared to the Sanger sequencing. So overall, the pickup rate of patients who had very few percentage of neoplastic cells was also a little higher when you used NGS in these patients. So this is a frequent one. I think this is important practical implications that we see in the clinic, that if you have a small sample, it might be better to prefer NGS over other routine techniques. And these were this was a list of EGFR mutations that were observed in this study, and some of the mutations which Senthil also described were found to be responsive, and many uncommon mutations which were undefined or were not reported earlier were also picked up by this method of upfront NGS. And this describes a list of cases where the uncommon EGFR mutations were picked up by NGS but were not picked up by Sanger sequencing. And that underscored the value of doing an upfront NGS panel if you want to think about picking up uncommon EGFR mutation. And the issue of picking up uncommon EGFR mutation is really becoming very critical, because we know that if they are sensitive mutation, then you have an opportunity to improve the survival of these patients with even with the available TKIs. And this was one of the example quoted in this article, that these were two patients. One was a cytology, one was a biopsy. And in both of these, you can see that the cellularity was low. The percentage of neoplastic cell in the sample on the left was just about 35%. And on the right side, it was still less, it was just 5%. And the Sanger sequencing did not pick up any mutations. It showed negative results. But when NGS were run on these both samples, on the left, it showed 2 EGFR mutations, and on the right, it showed an LAD58R mutation. So the conclusion was that NGS offers several advantages over Sanger sequencing. It has a very high analytical sensitivity. It can screen the entire nucleotide. It can do entire nucleotide sequencing. It can have a semi-quantitative report, and it can analyze many sequences in a single run. So it has a very high throughput. So our own colleague, Ullas Batra, had an e-poster which I stumbled upon at ISMO Virtual 2020. And he described a spectrum of uncommon EGFR mutations missed on a single gene testing, but detected only on NGS. And look at the variant allele fraction that Senthil was referring to in his study. So it again underscores the importance that you must use NGS upfront if you want to screen your patients for uncommon EGFR mutations. So the prevalence of uncommon epidemial EGFR alterations detected in ctDNA. Kumar was talking about liquid biopsy, and frequently it's not possible to have a tissue or an adequate cytology sample. And this is a study which is presented at the ASCO Virtual Scientific Program, and they found that in East Asia they had this NGS platform called Garden 360, and they studied plasma from 820 non-squamous non-small cell lung cancer patients, and they found that the pickup rate with this technique in a liquid biopsy was almost 9%. And in fact, there was an interesting observation that uncommon EGFR mutations were more prevalent than actionable biomarkers in the region. Whether it is to do with some technique, whether this is clinically relevant, we do not know. But again, this data support the use of NGS testing methods to identify patients who are candidate for appropriate EGFR targeted therapy. So when it comes to thinking of, when you think about even non-classic or uncommon EGFR mutation, even a liquid biopsy might be a valid option if you do upfront NGS. So, NCCN recommends whenever feasible, testing by a broad panel-based NGS to identify all the mutations that you are looking for. And it also mentions that many of the less commonly observed alterations in the EGFR, which probably account for 10%, the incidence might increase, and some of these are responsive to EGFR. And as you use more and more NGS, you may have increasing number of patients who have additional EGFR variants or uncommon mutations, the clinical implication of which remains to be established. So
thank you very much, Anand. Your time is up. We'll have to move to the next session.
All right.
So you can just conclude in half a minute.
Okay, so the main question now, if you think of scanning the patient for all classic as well as uncommon EGFR mutation, NGS is the way. It will save time. It is equally cost effective. It is feasible. Many Indian centers are picking it up. I think we all community oncology should start using upfront NGS. Thank you, Purvish.
Perfect. Thank you very much, Anand. We can now move to the next part of the session, please.
Thank you so much, sir. We'll move on to our next part of the session. Our next speaker is Dr. Nitish Rohatgi, medical oncologist from New Delhi. Over to you, sir. Sorry, so now you can share your screen.
Okay. Actually, could you do my slides? I've had to. Do you have a backup or should I try?
Sure, sir. I'll just play your slides.
Please, yeah. Thank you very much, Dr. Parikh, for inviting. Always very information-filled, very well thought of series of lectures. I think the key lecture for me is TKIs in EGFR, non-small cell with brain met. So I'll kind of confine myself to that alone. Next slide, please. Now, this is not a small problem. And there's a very interesting article recently from Future Oncology looking at a series of previous articles and papers suggesting that we can have a significant impact on the quality of life and quantity of life when patients with or without brain metastasis. And you can see that there's a separation of curve just by the fact that there's brain metastasis in this group of population. Next slide, please. Now, what they did was they also looked at the effectiveness of first generation TKIs and said that the response rate, next slide, please, was anywhere between 25 to almost 75%, with a PFS of anything between 3 to 20 months. So by no means are we saying that this is an ineffective therapy, while I think the world at large is trying to put that across that this is ineffective. It is maybe less effective than many other treatments that are available today, but it is not ineffective. And in some patients, at least, it may be a more effective treatment option than chemotherapy, certainly more tolerable treatment option than chemotherapy. So I would put a first generation TKI in brain metastasis certainly into consideration when I'm talking to these patients. Next slide, please. Now, having said that, we clearly saw that these numbers were not too great. 25, 30% is not a very great number. And that led to some preclinical studies of the third generation TKI, osimertinib, which, as most of the very learned audience in this already know, has a significantly stronger ability to bind to EGFR TKI. But what's very interesting is it was unaware whether it had the ability to cross the blood-brain barrier. And this was the initial studies in 2015-16 that, as you can see, when compared to gefitinib or osimertinib and afatinib, both first, second, and third generation TKI showed that from plasma to brain, you're seeing a very significant increase in the ratio there, suggesting osimertinib could go into the brain extremely well. Next slide, please. And a further affirmation of that was not only the fact that in rat model, this is rat model, where you can see the increased activity of the labeled drug in the brain as compared to the other three, but you also saw the brain metastasis in the rat brain going down. Next slide, please. Now that obviously led to the CLE-FLORA trial, where we saw in 2018 the data on PFS benefit. Next slide, please. And we saw that there was a fair amount of CNS metastasis in 20 to 25% patients in the slide. So this was as compared to Archers, where the brain metastasis was excluded. In Flora, 20% patients with brain metastasis were included in the study. Next paragraph, next slide, please. Now that in brain only, of course, the study was positive for a PFS benefit, but brain only, even brain only metastatic group, we saw that there was almost a 6 months advantage in PFS, and you can see the separation of curve. And now note very carefully that the separation has started at month 3 itself. So it's an early separation, it's a sustained separation, clearly showing that osimertinib is a very effective drug, which is effective EGFR TKI inhibitor, but also reaches the brain very nicely and clearly. Next slide, please. Now we have, since they had overall survival benefit, next slide, please. This came out last year, and we know that the EGFR TKI had an overall survival benefit at a hazard ratio of 0.8 with a confidence just touching 1. Next slide, please. But interestingly, there was a smaller population here, and so the confidence interval in the brain-only metastatic disease crossed the line of unison. And so we can't confidently say that. Having said that, I do believe it worked. And there was a big crossover in this study. So I don't think that we can take away the fact that we clearly have a PFS benefit. Now, it's also to be reiterated that this group, the PFS in the brain, has a significant impact on quality of life in a metastatic setting. And that also pushes me for considering osimertinib in first line from a point of view of brain metastatic disease in EGFR positive patients. Next slide, please. The further question of osimertinib working came with studies retrospectively looking at leptomeningeal disease. Next slide, please, which most of us know are the very difficult to treat patient, and this was irrespective of 790. And we saw that osimertinib versus non was a big difference in a very difficult group. You can see the sharpness of curves as they're falling, and a slight separation in the red line in the osimertinib group. Next slide, please. EGFR TKI plus BEV for patients who can't afford osimertinib is also an option. We must not forget that there is some conjunction between the first line EGFR TKIs and bevacizumab. Next slide, please. And this was a presentation in 2019 in ESMO, but clearly the majority of patients were first and second generation TKI, and we saw a difference there in the combination of both. Next slide, please. Now, what I'm trying to say here is that in patients who can get osimertinib, I think it is certainly the drug of choice, but that's not the only treatment option. We first spoke about first generation EGFR TKI having some efficacy already. We spoke about osimertinib may be the best drug in the class, but there is another option, and NEJ026, which was a study of erlotinib, bev, and no trial comparison between that and osimertinib, but clearly showed there was a significant population with CNS metastasis. And yes, again, it crossed the line of unison, but the diamond is towards the left, showing there is a benefit in the group. Next slide, please. With that in mind, obviously, there is a very interesting study for the worst group, which is leptomeningeal of osimertinib and bev. So you're kind of combining the best generation EGFR TKI with what is the combination drug, which is bevacizumab. That seems to be increasing the efficacy of these agents when we're talking about both 790 and brain. And I think we saw that all the way back in ETOP, which was a phase 2 study. Next slide, please. Now, this is the CNS activity of the other VEGF inhibitor ramucirumab in combination with osimertinib in 790 positive EGFR mutant patient. Next slide, please. Which again shows that these are all early data, but shows that in patients with or without radiotherapy, there was a benefit in CNS metastasis. Next slide, please. Now, so if I were to put it all together in the last minute or two, first point is first generation EGFR TKI is an effective option against brain metastasis in EGFR mutated patients. So I cannot refute the fact that despite of the fact that in comparison to other drugs, it may be less effective, it is and remains an effective drug. Now, please note, and this is very important, and I think we've had a lot of discussion from Senthil and then Dr. Anand about the fact that this is almost an entirely data on deletion 19858 and not rare mutations. So please, please, please do not equate that, especially with brain metastasis, because you will not get a second chance. Osimertinib has the best data, and there's no question. We've got a randomized trial, it's prospective. We had PFS benefit clearly, and we could have had OS benefit had the data been maybe larger, more powered, or in fact, there was no crossover. But that's that. But it clearly has the best data, and to my mind, should be considered as the standard of care in this group where brain metastasis is in consideration. Bevacizumab and lottery make a great second option now, especially in India, where the cost of bevacizumab has come down and alotinib is easily available. So for where osimertinib is not available, I would actually consider this as my treatment of choice. And I would not ignore this for even a slightest second. However, I think the combinations of both bevacizumab and the other VEGF inhibitor, ramucirumab, in the second and third generation EGFR TKI are promising. I think they will be waiting to get matured. And once they are available, I think this field will open up to a lot more. At the moment, I would stick to osimertinib or the combination or lottered of bevacizumab, otherwise chemotherapy as standard of care. Thank you very much.
Thank you so much, sir, for the wonderful session. We'll move on to the next part of the program. This is the interview. Our two expert faculty are Dr. Randeep Singh, who is a medical oncologist from New Delhi, and Dr. K. Pavitran, senior medical oncologist from Kochi. Over to you, sir.
Thank you, Kashish, and thank you, Purvish, sir. I mean, it will be quite interesting as one of us belong to North India and the other belongs to South India. So I think Pavitran sir is there. And hi, sir. And unfortunately, Delhi was actually, I mean, has really gone a bad phase in last 2 weeks, and pre-Diwali, 2-3 days, and post, actually, it was very worse. And you cannot deny that we have actually seen the second wave, which was quite bad as compared to the first wave. I mean, we had more deaths, more severe infection, and a more fearless population to face. So, sir, what is your impression about, I mean, are we in the second wave or still in the first wave, or some part of India is in the second wave, some in the first wave? And what about the place where you practice, I mean, Kochi and Kerala?
Can I share the slides?
Sure, sir, you can share the screen, sir.
Because, yeah, because 1 minute. That will help in yeah, just to show the pattern. In the USA, they have gone to the third wave as per the Johns Hopkins website, the COVID data, and UK in the second wave, and India is still in the one big wave. But as per the recent survey done by Dr. Purvish, it was in the 48% of the respondents said that they are facing a second wave. And as Dr. Randeep told, many places like Delhi, Ahmedabad, Rajasthan, Haryana, there was a definite recent number. But Kerala, as you can see in the graph, there was a peak incidence in the last 2 months, that is September and October. And now it has plateaued, and our test positivity, the community test positivity, continues to be at about 10%. That is the current status now. We are not yet faced a second wave.
So Kerala, so this is the first time we have seen such a high number of cases, or it was earlier also during lockdown? I mean, April.
No, not at the time. Actually, it peaked in the last 2 months, September, October. That was a peak. Now
So
it
peak
is
has
coming
come.
down. Yeah.
So peak has come late, but this is the first wave. I mean, because
Yes,
Delhi had
yes.
a peak earlier in May, June, and then now it is actually
Yes.
the second wave, which has slightly more peak. I mean, peak is also more and more severe also.
Yeah.
So, I mean, this question goes a bit different for you, sir, but for us, like how confident we are, I mean, to manage COVID and lung cancer together in the second wave, or at least everyone has an experience of having at least 2-3 patients in last 6 months. I mean, everyone had patients of oncology, unfortunately suffering from COVID. So are we more confident now than what we were in March, April when the lockdown was there?
Yeah, the few points that we learned are, because one is now we have learned to live with the new normal. That is, the precautions we know how to take and protect ourselves as well as our patients. And screening is routine for chemotherapy patients as well as high-risk patients. Now we are doing routine screening, and this is likely to continue also. And patients are also very careful. They take care of all the precautions. And as per our data, we tested our chemotherapy patients, and we found that the prevalence in the asymptomatic patients was only 0.88 versus community rate of 10%. So our patients are really aware, and they're taking care of themselves. So the positivity is really low.
No, you're right. I think in the initial phase, even if we used to get a referral to see a patient, I mean, someone who was admitted with anemia and COVID, we were very fair. Yeah. But all of us have had a close brush with the patient seeing in the OPD. And we all know that momentarily seeing the patients, you will not contract COVID, because that is, I think, one of the very important points, because initially, even if we used to have a patient walking down the corridor, which was 6 feet away, the staff
we were afraid.
Sir, the patient has gone and ab wahan se mat jana and all that. So all that things actually are now gone. And we have also seen patients coming up very good. I mean, reviving from COVID while taking chemotherapy. Sometimes they have received chemo and within second, third day, they are getting diagnosed with COVID and recovering well. So definitely the confidence level is much more. But what I feel, sir, and I think everyone will concur, is that the comorbidities such as age, diabetes, renal failures, these all actually matter a lot, that how the patient will recover.
Yeah, that really increases the case fatality rate.
And now we know that this is the lung cancer Chakravyuh, and if you talk about lung cancer, I think it is very difficult. And I also have patients we all have lung cancer patients, and they do come with fever and cough, which is the classical presentation of COVID. And the terror is so much that if anyone is coughing in some OPD in oncology, I mean, the other 3-4 OPDs are worried that why that patient is coughing and why he is there. And then I have to come out of the room and tell my staff and my other radiation oncology colleague that please don't worry, this is the lung cancer patient and his COVID is negative 4 days before. That's why he's coughing. I mean, it's very difficult. How do you cope up with this? Because symptoms as well as toxicity and pneumonias underlying with lung cancer is actually a big challenge in the diagnosis, especially at the time of diagnosis, as well as someone who is on immunotherapy.
Yeah, clinical, it is really difficult because the symptoms of both like viral pneumonia and lung cancer both overlap a lot. And usually both will have fever, dry cough, dyspnea, but symptoms like anosmia or diarrhea may point to COVID more than lung cancer. There is one clinical differentiation. And regarding radiology imaging, again, the findings are very difficult to differentiate. But there are some points like this is an example just to show you that these are the peripheral ground glass opacities, bilateral ground glass opacities in this patient, and with or without consolidation, and visible intralobular lines, and also multifocal ground glass opacities. And another feature that can help is what is called the reverse halo sign. That is central ground glass opacity with a peripheral rim of consolidation. That is called a reverse halo sign. This is not typical of COVID pneumonia alone, but it can occur in other pneumonia like organized pneumonia and all. But these are the features that is a characteristic of COVID pneumonia. And other point is how to differentiate immune pneumonitis or chemotherapy or immune associated pneumonitis from the COVID pneumonia. Again, there are some points like in immunotherapy associated pneumonia, the infiltrations are, the GGO are confluent or perihilar. It is more perihilar than peripheral, and increased interstitial markings and interlobular septal thickening, as you can see here, and subpleural ground glass opacities. This again more in favor of an immune pneumonitis than a COVID pneumonitis.
I think that picture is actually quite helpful, and many of our radiology colleagues, the radiology colleagues are also not able to give us a clear answer. And the picture clearly shows that if you have a perihilar opacities and the GGOs, it goes in favor of immune pneumonitis, because most of the patients we tend to put on immunotherapy, and a very low threshold of checking for COVID-19 because the symptoms are overlapping. And sir, what is your current policy of testing the COVID patients and your daycare patients on chemo? And has it changed in last 6 months? I mean, in March, April, vis-a-vis in November. What are we following? I mean, what are you following in your institute at Amruta?
Initially, we were not at all doing, because we were not having any case at the time. But all changed after August, when one of our patients became positive. Then all became quarantine, staff got quarantined, and so many issues. Then we started routinely testing, and now it is a routine. And we routinely test all the patients coming for, especially for chemotherapy or admission. All these patients are tested, and all admissions, OP patients we test by antigen testing, whereas IP patients we test by RT-PCR. That is a routine policy of the hospital.
Patients, daycare who are starting their chemotherapy, they are by antigen or by RT-PCR?
Antigen, daycare by antigen, because of the delay in getting the results, we do by antigen.
And we test them prior to each sitting. Suppose they are on 3 weekly, so are we?
Usually by once in 2 weeks we do.
Okay.
Because if it is weekly chemo, we do it in once in 2 weeks. Once in 3 weeks, definitely.
And so everyone undergoes once in 2 weeks antigen testing.
Yes.
Okay, fine. So at my center, we are just doing it at the first time. I mean, everyone has a different policy as per the institute and the COVID committee. Many centers are checking every 2 to 3 weeks in Delhi. And I think the right policy is to check every 2 to 3 weeks. And of course, the rapid antigen test is now available to most of us.
Yes.
It gives a rapid test and can be used in case of frequent testing, as sir has suggested. And Dr. Pavitran, what do you do if you have a COVID positive patient? And we all know that in oncology, we have two sets of patients, both symptomatic and asymptomatic. One who is detected, as you said, by doing an antigen test, and one who really presents with high-grade fever or cough or breathlessness. So how do you follow these patients? I mean, apart from the routine antiviral therapy and zinc, vitamin C, and doxycycline, ivermectin, which our physicians help us, and home quarantine, how do we put them back to the track in our daycare and chemo or immunotherapy? I mean, do you wait for 2 weeks, 3 weeks, 4 weeks, positive, negative?
So the usual and what we follow is, if it is symptomatic patient, we can start chemotherapy when they are asymptomatic. That is one, clinical, or at least 3 weeks after the symptom onset, or a negative COVID, antigen or RT-PCR test. But the many recommend against retesting, because the test can be positive for a long time, even though they are asymptomatic or free of disease, because even the dead virus can be picked up by the RT-PCR. And one point that can help in differentiating whether it is active infection, ongoing infection, or it is a dead virus is the cycle threshold. And the cutoff, what is told is, if the cycle threshold is more than 35, then it indicates low viral load, and it can be taken as a negative test, even though test is positive. But if it is less than that,
if someone is asymptomatic and showing a COVID positivity after 4 weeks, and as you told about the cutoff is more than 35, are you okay to put them back on chemotherapy, or if they are in a curative setting, especially?
Yeah, definitely, because this is what the guideline registries also tell the same thing. Because if they received chemotherapy within 4 weeks of the infection, it is not associated with an increase in the mortality. So it is safe to give chemotherapy for such patients.
Thank you, sir. Can you in brief tell what alterations in treatment regimens, and if I can request you to keep it very brief, as we are 2 minutes, and cover these, that what alterations we have done with respect to the doses, frequency, and use of supporting supportive therapies and others. And
main thing is, immunotherapy is not associated with increased risk, but registry data shows that combination immunotherapy and chemotherapy, there is an increased risk of mortality. And immunotherapy practice has changed from usual 3 to 4 weeks. It has become now routinely to give 4 to 6 weeks because from PK PD data shows that that is effective and can be stopped after 1 or 2 years instead of continuing long. Another point is like use of growth factors. The previous cutoff was like more than 20%, that is high risk of febrile neutropenia to give growth factors routinely. But now the practice changed to give it for the intermediate risk patients also. That is, even if the risk of febrile neutropenia is 10 to 20% also to give growth factors. But there is a small risk of respiratory failure because of the increase in the WBCs. But this risk is very low and it outweighs the benefit.
I think we will skip the triage in the interest of timing. And how has been the teleconsult? Actually, it has been quite, odd. If I have to comment my experience, my teleconsult has gone down over last 2 to 3 months since the complete scenario is unlockdown in Delhi. People are on the road celebrating Diwali and they do come to hospital also. So there is the teleconsult has drastically gone down of April, May, June to November, December. I feel it is a bit odd, but this is what is my experience. As
yes, our
sir.
pattern is different, and there is an increase only. Yeah, previously it was only once in a while, and it was non-existent teleconsultation, but now it is a routine.
Okay, and and I think in the interest of time, before Purvish sir switches both the audio and visual, the last thing which I feel is very interesting, and the comments on, COVID experience, of course, this is new to the whole world, but it has taught us some lessons. And it has also taught us that if we are making some changes in the protocol, if you're deviating from the guidelines, it is not necessary that we will not be able to achieve good results. Sir, can you share your experience and give the last message to the audience?
Like minimizing infection and maximizing treatment capacity, and routine care should not be put on hold because each 4-week delay in treatment can increase the mortality by 10%. This is one of the recent reviews in JAMA showed and BMJ showed. And immunotherapy dosing frequency, we have changed the frequency of administration and reducing in-person visits to hospitals through the teleconsult. Definitely it has drastically come down, especially follow-up visits. And another point that we learned is cancer care can be delivered to distant or remote areas through telemedicine. That also has become a routine now.
Thank you, sir. I fully agree. Teleconsults, telemedicine, virtual conferences, and the courage that yes, you can treat at least gefitinib, erlotinib, capecitabine with telemedicine has definitely been there, and everyone has treated these patients during lockdown and unlockdown. Thanks a lot, sir, for your wise advice, and thanks a lot for to the organizers for giving me a chance to have a chat with my senior colleague and Dr. Pavitran. Thank you, sir.
Thank you. You're welcome.
Thank you very much.
Thank you so much, sir.
Go ahead, Kashish.
Yeah. So we'll move on to the last part of the program. Our expert faculty who will be giving the take-home message is none other than Dr. Vamshi Krishna, medical oncologist from Hyderabad. Over to you, sir.
Good evening, everyone. I hope my slides are visible and I'm audible.
Yes, sir. Your slides are
there is some
as well,
there is some cyclone Nevar offset, so I might have some internet issues. If I have that, I will ask you to share. So we had a fantastic around, I think, 2.5 hours of lectures and talks and tips. Really a unique tips and solutions Chakravyuh, which has been very, very enlightening. We started off the day with Dr. Nikhil and Dr. Minish talking about Mediclaim tips and how to get insurance companies to pay for oral chemo. So the points which were very importantly made is that oral drugs are not chemotherapy. That's how the insurance looks at it. So one way to avoid it is to go for a cancer comprehensive policy. Do not go for a general Mediclaim, but go for cancer comprehensive policies which cover oral drugs. The next very interesting thing which Dr. Minish was talking about is when you have alternatives or generics, try to go for those cheaper options, and importantly, use those options which can be used for a longer term. In this case, insurances tend to give your approval. It's always good to have second opinion, a TMH opinion, or a guideline which you can write and send to them. Please check the case history which is being sent. Do not include data or things that are likely to lead to higher rejection rate. Guidelines need to be followed. IRDA guidelines have specified specifically that we can use oral chemotherapy and that they should be reimbursed. Dr. Purvish did put up in his comment that such a document exists. Go to the website, of IRDA, look at all their documents in PDF format, download and put it to the insurance company. 50% of patients will get the benefit if the doctors take the effort to write to them. So do not just assume that it is not being done. It can be done. Most important practical tip, follow the guidelines, better policies, and affordable and long-term treatment. These were my key takeaways from this very interesting lecture. I'm sure many of us would now start talking to the insurance companies more. The second lecture was on financial tips of non-banking healthcare financial services for patients, moderated by Dr. Amish Vora. First and foremost, something which many of us do, take the support of the pharma company for free samples. Take their support for giving more number of free samples if you are able to give them a bigger business. That's a personal choice. We can talk to them. Trusts will support. Hospitals might end up supporting patients and might help in reducing the fees and reducing the bills. Again, do not assume that it cannot be done. Often we talk to them, we realize it can be done. Getting patients to fund either by putting, like Dr. Ghanshyam said, a part of some money coming in from other sources into using for their funding. Clinical trials is a very, very underutilized thing in India. We have started using it, but more the trials we do, the more access to free drugs we will have. And again, all of us have experience of these patients who have gone on multiple drugs because of clinical trials. Very crucial. Try to establish a clinical network, try to see which hospital is doing the clinical trial and send patients there. It is for the patient's benefit. They're not our patients or anybody's patients. Interesting talks about the EMI and the loan facility. These are usually run by the NBFCs where there's no liability on doctors and hospitals. I was a bit skeptical about this, but Dr. Somshekar's Manipal experience of 4,000 patients seems to indicate that this might be a workable model. Again, whether it is equally applicable across India, whether it's up to a city, whether the hospital management agrees, we need to look into it. But then it can be done. Finally, I think the last part done by Dr. Purvish was very important about crowdfunding. Remember, the crowdfunding may not cover the full therapy. They may cover a part of it, but that little part might be enough to tip the patient into getting a complete treatment. Kito was one which has been talked about, seems to be a reputable company which we can explore. A lot of personal experience of people who have done their own crowdfunding for patients, plus of course trying from Chief Minister's Fund, other funds. Try to get a social worker, try to get somebody who is involved in this, and then you can see the difference it makes for the patient's treatment. Next talk was by Dr. Ashish and Dr. Raju, which was a talk down memory lane as to how lung cancer mutations have evolved to precision oncology. It was very fascinating to hear Dr. Raju say on how diagnosis used to be the only treatment for patients. Then we had a paradigm shift with targeted therapy. Phase 3 ISL, a lot of Indian centers participated and got experience with the trial and Jeftinib. There are, of course, a lot of hurdles in testing which need to be overcome. Possibly the future could be improvement in liquid biopsy and detecting the newer targets. Most importantly, I really like what Dr. Chaco talked about, reduction in costs and how we need to take a more holistic approach in pricing by the pharma companies. So I wish all the pharma companies listening would get into this. Though to be fair, drugs in India are still available for much cheaper than the West, and that's a point we should not ignore or simply reject our Indian companies' efforts to bring down the prices. Liquid biopsy, Dr. Kumar Prabhash, as usual, gave a wonderful talk on how the various types of liquid biopsy are there, whether you do CTC, cfDNA. He looked upon where all we can use this technique. Early detection of lung cancer was promising. However, he did very emphatically say mutations being there in the blood are not equal to a cancer. And that is very important. These mutations may or may not reflect a cancer developing in the future or may not reflect a cancer being present right now. However, doing this test in a combination with the LDCT seems to be the way forward. Concordance of liquid biopsy with the tissue biopsy around 96 to 98%. However, he did specify that the sensitivity is only 80 to 90%. So maybe as of now, you might end up missing a few patients if you rely only on the liquid biopsy. Let's still stick to tissue biopsy, but if you do not have access to tissue, liquid biopsy seems to be pretty good. There is a time delay to consultation with the patients coming with the results, which could be obviated with a liquid biopsy. The amount of tissue available, only 60% in his studies had adequate tissue. 35% of patients start treatment before the results come. So if you're able to ensure early results and results in all patients with the help of liquid biopsy. That's probably the plus points. Less human resources are needed. You don't need an intervention radiologist. You do not need a CT guided biopsy. And trust me, these are not things which are easily available in all hospitals. Monitoring responses, very intriguing. Early days yet, let's not jump the gun and start everyone starting Monday. But yes, this is something that can be looked at. The next was surviving sequencing strategy with TKIs in NSCLC, panel discussion. There are several options of how to sequence TKIs. One thing is TKIs have better PFS than chemotherapy for common mutations. Not all the TKIs are equal. Would you want to use your first line first? Would you like to use a combination? TKI, TKI VEGF, TKI chemo, the pros and cons, the benefits, the side effects, all were discussed in detail by the panel. And well, as has been pretty much commonly done, there is really no one consensus. It has to be an individualized treatment sitting with the patient and with the doctor. Immunotherapy working in L858R, intriguing data, again, something which probably in the days to come we are going to hear more about. Uncommon mutations, you have afatinib and osimertinib. Sequencing is very important. Remember, T790M will not happen in all the patients. Potentially, the geotag showed that more patients treated with afatinib would have a T790M. Observational study, retrospective analysis, lots of kind of issues with the study, but still intriguing data. So if you want to use afatinib, this is one reason why you would probably want to use afatinib. And I am a fan of that drug, so that's how it is. Next was this wonderful forensic analysis of how uncommon mutations should be done by definitely a very, very uncommonly wonderful Dr. Senthil Rajappa. And he talked about the testing strategy to begin with, sequential and NGS. Again, by and large, we are shifting to NGS, but sequential still has its benefit. Would you start therapy only if it is symptomatic patient? Please look at the uncommon EGFR mutation. I think that is the take-home message from his talk. Look at the report. Do not just try to see a summary. Just look at what exact mutation is there. He classified uncommon mutations again into the major uncommon, the compound mutations, and the insertions. When you looked at the major uncommon, basically the S761, the G719, and those are the common ones. So they are the common uncommon mutations. Afatinib seems to work. Osimertinib seems to work. Interestingly, he showed enough data that chemo seems to work in this set of patients as well. Compound mutations overall seem to do better than just the uncommon mutations alone. So these compound mutations could be a common and an uncommon, or an uncommon with some other kind of mutation. They seem to do better. The data seems to favor either afatinib or osimertinib. But as he said, 600 mutations are there. Look at what mutation you're dealing with. Exon 20 insertion, well, bad. We don't have drugs. Pozutinib has failed. Except the A767, it sounds like a new model of aeroplane, but that's what we are dealing with. So it's an easier way to remember probably. Honestly, haven't seen this yet, but it is something that we can look at. The type of uncommon mutation is very important. Not all uncommon mutations are the same. So go back to your literature, look into the internet, try to see what mutation you're dealing with. Next, Dr. Anand Pathak talked about uncommon mutations and how NGS helps. Uncommon mutations range from 4 to 20%. Using NGS, you have an increased pickup of compound mutations. You have an increased pickup of more uncommon mutations. It is better for smaller samples. Concordance is reasonably good, definitely better than Sanger's. He did show the Indian study by Dr. Ullas, which shows better pickup of uncommon mutations by NGS. So again and again, willy-nilly, NGS is where we seem to be heading towards. Dr. Nitesh spoke about TKIs in EGFR mutated NSCLC with brain mets. Most important point, the first generation also work. Let's not completely confine the first generation TKIs to the dustbin here. They do work in brain metastasis, though yes, second and third generation seem to cross the blood-brain barrier and do better. Interestingly, with brain metastasis, both osimertinib and bevacizumab erlotinib have a significant PFS benefit, but no OS benefit as of now. So given the PFS benefit, given the increasing role of radiation, you would want to use one of these drugs. No OS as of now. Leptomeningeal disease, small data, but osimertinib seems to work. Bevacizumab, I apologize for this. It's erlotinib and ramucirumab is a promising approach, especially in the second and third line. The last session was a very interesting discussion by Dr. Randeep and Dr. Pavitran. For lack of time, I could not really type these, but they talked about how it has impacted our services, how people are afraid of COVID around a couple of months back, whereas now we are much more sanguine about it. We don't simply run out of the way. We don't have people now shouting, clear the corridor when a patient walks through. We are aware that yes, you need a more prolonged exposure, a maskless exposure. That is very, very crucial. Only when you're without a mask and you sit in proximity to a patient, you would be liable to catch COVID. He spoke about how practices are changing. We probably will make some changes in terms of the type of drugs given, the scheduling, but we cannot change the science overnight. We cannot simply change the medicines. Dr. Pavitran showed us good images of how we should look at the differences in terms of the imaging and what we should talk to our radiologists about. Teleconsultations is something, yes, which is personally also has come down a lot, but I think that goes ups and downs. But yes, using teleconsultations for faraway patients, reducing travel, and more importantly, communicating frequently with the patient. Those are places where it would help. Overall, COVID is here to stay till we get enough vaccines, and even then we are going to see these occasional cases. So it will not vanish from this earth very soon. So that's my summation of what happened over the last 2.5 hours. I'm sorry if I missed anything. It was purely my fault. Any question and Q&A session, sir, that we can take?
Sure. Thank you very much. I think you've done a fabulous job of summarizing everything, and it just tells us that you paid more attention than the people who prepared the lectures. So
Right,
there are several questions,
Sure,
but
sir.
some of them may have already been answered. So you can just skip
Sure,
them
sir.
and move on to the next.
Sure, sir. So the first question was from Dr. Amish. Legally, oral TKIs are allowed. If yes, how do we fight? So like Dr. Manish discussed, yes, they're allowed by the IRDA regulations. How do we fight? We have to fight by talking to them and writing to them, and by applying, putting a copy of the guidelines. Can we take insurance for cancer if a patient is a smoker? That was my question. Dr. Manish or Dr. Amish, if you're there, can you take this?
I'll take it.
Yes,
It's
sir.
possible. It's possible to take insurance.
Okay, so
Yes,
should we acknowledge that they're a smoker?
Yeah, we should, because again, IRDA said that just because a person has a bad habit does not mean that insurance should be denied or should not cover. So
Perfect,
there's
sir.
a circular from IRDA about that as well.
Wonderful. So Dr. Jovita has a rather long question. Essentially, lung cancer due to occupational hazard, can we go and sue the government, or will the government allow insurance for these patients specifically? Dr. Purvish, your take on this?
I have no answer for this.
I don't think we can blame the government. The government will not listen to us.
Right.
Next question. So Dr. Jovita asked, in CA ovary, multiple lines to be used, efforts a clinical trial. Okay, this was just a comment. Next question. From Dr. Vishnu Gopal, anyone making use of PM relief fund in private sector? Again, the answer is people are trying, but no clear, it is not a definite solution. Not everybody will get it. I think it's just a matter of
I think
hit and run.
the people who have the connection will get it. For
Perfect, sir.
instance, from Rajiv Gandhi Cancer Institute, a significant number of patients are getting from PM fund because of their network.
Okay. So personally, in our center, we get from Chief Minister's Fund, but we don't get from the PM. Probably south of the Vindhyas, it's PM is seeing a little less of us. So Milap works the same way as Keto. Any experience, sir? You could take this, or
No experience.
No
But
experience.
I think that somebody, Dr. Shah mentioned that he had used it.
All right. Can we do amplified PCR techniques like DDPCR? Dr. Kumar Prabha sir, are you there? Or if Dr. Sendil, anyone is around, can they take this question?
So Kumar sir is not there.
Kumar sir is not there.
Sendil sir is not there.
Okay, done. So I think I'll just take this. Yes, we can do DDPCR on liquid biopsy. In fact, that's how we are doing testing for the T790M. Dr. Amish wants to ask which so many drugs, that's a comment. Next, Dr. Purvish made a question. I think these are all chat boxes that was going on. So let me just sum up the next 3-4 questions. The discussion really was on whether a TKI VEGF has shown a better OS survival than others. This was a mistake from my side. I kind of thought that there was a better OS survival, but as of now, the relay trial, OS results not published. The NEJ trial has not shown any benefit for the combination in terms of overall survival. Dr. Rajesh Jindal wants to ask if we can use OSI plus chemo for systemic and brain mets together. This discussion was, Dr. Nitesh, are you there? Dr. Nitesh Rudgi, I think he was talking about the brain mets.
He's not there.
He's not there. So again, osimertinib and chemo together, off-label, no data right now. We have to wait for the FLORA-3 to tell us the results. Till that, we will not know. Dr. Giri says whole brain RT is supposed to open up the VB. Yes. So will first generation TKIs work equally well? Nobody knows. Again, whole brain RT is being rapidly giving way to SBRT or SRS, as somebody pointed out in the comments. So probably we don't really know the answer to it. I think that's the best answer. Next question.
That's it.
That's it. So I think that was the question. So over to the organizers again.
Right, perfect. Vamsi, thank you so much. And I take this opportunity to wish you all the very best. So in your new venture, you become Director of Medical Oncology at Asian Institute in Hyderabad. So wish you all the best.
Thank you, sir. Thank you very much.
And I thank all the participants for taking time off and being here with us till as late as almost 9:30. I now give back to the event managers and they can close the meeting.
Thank you so much, sir. Once again, on behalf of the organizers, I would like to thank our supporters, Boehringer Ingelheim, Intas Oncology, and Gene Evolve for their wonderful support. With that, I would like to thank all the participants who have also joined and wish them a nice weekend.